Good morning, ladies and gentlemen. The International Symposium on Holistic Care and Healthcare Quality 2026 will begin shortly. Please take your seat and ensure that your mobile phones are turned off or set to silent mode. Thank you for your attention and cooperation. 2026全人照护与医疗品质国际研讨会即将开始，敬请各位长官及贵宾准备就座，并将手机调整为静音模式，谢谢。Good morning, ladies and gentlemen. On behalf of the organizing committee, it is my great honor to welcome you all to the International Symposium on Holistic Care and Healthcare Quality 2026. Now, please join me in welcoming the Superintendent of the Tri-Service General Hospital, Professor Cai Yiting, to come up the stage to deliver his opening remarks. Welcome.
Okay, President Lin Ziyuan, Chairman Zhang Shangchun, Chief Executive Officer Fang Zhenzhong, and Dean Wu Yizhe, Superintendent Jian Zhicheng, and distinguished speakers from Singapore, Japan, and our honored guest, colleagues, ladies and gentlemen, good morning. On behalf of the Tri-Service General Hospital, it's my great pleasure to welcome you to join the 2026 International Symposium of Holistic Care and Healthcare Quality. This gathering is especially meaningful for us because we just celebrate our hospital's 80th anniversary and bring together experts from Taiwan and abroad to explore the future of healthcare quality, patient safety, and holistic care. As our societies age, healthcare needs to become more complex, and artificial intelligence advances rapidly. Quality in healthcare requires patient-centered thinking, cooperation across professions, and attention to the well-being of healthcare teams. So today's program is them how cooperative leadership can drive interprofessional cooperation and holistic care. It also explores how shared decision-making can support earlier integration of palliative care, how well-being can shape the health profession community. and how AI can support holistic and interprofessional medical education. Together, this perspective offers valuable insight for clinical care and workforce development. This afternoon, the discussion will expand to quality and safety in healthy aging society, holistic and sustained healthcare, and the challenge of quality management and shared decision-making as a pathway toward national recognition for healthcare quality. From governance to clinical practice and from innovation to humanistic care, this topic reflects our theme. Is that excellence is in governance and holistic practice. Tri-Service General Hospital carries important responsibility in clinical care, education, research, and military medicine. We will continue to embed holistic care in clinical practice, use digital innovation to improve our care, and ensure that every quality initiative creates value patients can truly experience. In closing, I thanks our speakers, moderators, partners, and organizing team. May today's dialogue inspire new ideas and cooperation and help us build a more resilient, compassionate, and sustainable blueprint for healthcare quality and patient safety. I wish the symposium very success. Thank you. Thank you, everyone.
Thank you, Professor Tsai, for your warm and inspiring remarks. Please return to your seat. And now, ladies and gentlemen, it is our great honor to invite President of the National Defense Medical University, Professor Lin Zhiyuan, to deliver his welcome remarks. Professor Lin, please.
Superintendent of Tri-Service General Hospital, General Tsai Yiting, Dean Professor Wu Yizhe, and the Superintendent Professor Jian Zhicheng, and the distinguished speaker from United Kingdom, from Singapore, Professor Ye and Professor Gao, from Japan, Professor Yuhiro, and Chief Huang from National Taiwan University Hospital, all the faculty members and healthcare professionals, good morning. Thank you. It's a great pleasure for me to join with you in the 2022 International Symposium on Holistic Care and Healthcare Quality. I would like to thank all our speakers, moderators, and partners from Taiwan and abroad, inside and online, and to commend Tri-Service General Hospital and the organizing team for their fruitful preparation. As we celebrate the hospital's eighth anniversary, the symposium not only honors its distinguished legacy, but also demonstrates our shared determination to shape the future of healthcare. Holistic care, healthcare quality, and patient safety form a common foundation connecting education with clinical practice. Medical education must do more than provide knowledge and technical skill. It must cultivate healthcare professionals who understand patients, collaborate effectively, continue learning, and lead change. The development of AI-driven model of a holistic and interprofessional medical education from Tri-Service General Hospital to global practice demonstrates how technology can support both learning and patient care. Discussions on health, aging, sustainable healthcare, quality management, and shared decision-making as a pathway to quality excellence, further show that education must respond to real clinical and social needs. National Defense Medical University carries the important mission of education healthcare professionals who serve both the armed forces and the communities. We will continue to advance competency-based education in the professional learning and the international exchange, strengthen the connection between education and the clinical practice, and ensure that technology innovation remains guided by humanistic care and the professional ethics. You can find that what I say is almost the same like Superintendent Tsai, because I think the script is generated by AI. I hope today's symposium will provide opportunity to share experience, build meaningful connections, and translate new insight into concrete improvement in education and healthcare quality. May this symposium be a great success. Thank you.
Thank you, Professor Lin, for your kind words and encouragement. Please return to your seat. Next, we will have a group photo. May we kindly ask those seated in the middle remain seated, and those seated on both sides move toward the center so everyone can be included in the picture. 请坐在两侧的贵宾往中间走道移动，我们将拍摄一张大合影。Before we begin, I am the master of the ceremony. The organizing committee would like to make a brief announcement regarding timekeeping. To help keep today's program on schedule, we will remind you when you have 5 minutes and 1 minute remaining in your presentation, and remind you again when your time is up. Thank you for your understanding and cooperation. Now, it is my pleasure to invite the moderator of our first session, Professor Wu Yizhe, Dean of the College of Medicine at the McKay Medical University, to introduce our first speaker. Professor Wu, the floor is yours.
Okay. Good morning, ladies and gentlemen. I'm Dr. Yizhe Wu from the McKay Medical University, and it's my great pleasure and privilege to introduce our distinguished speaker, Professor Judy McKim. Professor McKim is an internationally renowned leader in medical and health professional education. She is currently the Dean and Professor of Medical Education at the Black Country Medical School and Professor Emeritus of the Medical Education at Swansea University, United Kingdom. And she's got, the very long CV and gorgeous experience. So just allow me to briefly introduce her previous work. I think over the past 35 years, she's held senior academic and leadership positions in the United Kingdom and internationally, with extensive contributions to curriculum development and accreditation and interprofessional education, faculty development, as well as the healthcare leadership. And her academic contribution actually are equally impressive, including 21 books, more than 350 journal articles and book chapters, and over 500 conference presentations. And she is also widely recognized for her work in clinical and educational leadership. And today, Professor McKim will speak on the collaborative leadership, an essential driver for interprofessional cooperation and holistic care. And most importantly, she will introduce her boundaried leadership model, exploring how leadership can build trust and bridge professional boundaries, and finally create seamless and holistic care for our patients. So please join me in giving a very warm welcome to Professor Judy McKim. Professor, please.
Hello, everybody. Good morning. I'm Judy McKim. I'm the Dean of the Black Country Medical School, and I'm really privileged to be with you today. Thank you to Professor Tsai, Professor Lin and the organising committee for the invitation to open this symposium, and congratulations to Tri-Service General Hospital on your 80th anniversary. I'm really sorry not to be with you in Taipei in person, and also the time difference slightly defeated me, but I'm delighted to be part of your day. I'm going to talk to you today about collaborative leadership, and my argument this morning has two halves. The first is about leadership itself. However, the second is about education, and my central claim is that you cannot have one without the other. So what am I going to argue? The first thing is that holistic care is a collective achievement. No one profession holds the whole picture. No one profession has total accountability in a shared leadership situation. Secondly, collaboration depends on leadership. When collaboration fails, we often look for individuals to blame, but the real barriers are hierarchy, professional status, professional identity, and system design. Every one of those is something leaders create and can change. The third point is that, and I think it's probably the most important, that leadership alone is not enough. Leaders can create permission for collaboration, but permission is not capability. Capability is built through education. So let me start by thinking about patients, which is why we're all here. So 2 examples in which every professional did their job, no one did anything wrong, however, the care was not still holistic. Think of a patient you have known, and I'll describe mine, and I suspect you'll recognize some similarities. Think about an older woman admitted after a fall, very common. She has diabetes, and she's got early cognitive impairment. However, she is the sole carer for her husband. This is very similar to my mother and how she cared for my father when she had early onset dementia. Over 8 days, she's seen by an excellent orthopedic team, excellent endocrinologist, diabetes team. The nurses, their team are great, physiotherapists, pharmacists, everyone does their job really well. She's discharged on a Friday afternoon. This is a common problem, isn't it? It's the weekend. Nobody has really asked who's looking after her husband. Nobody's taken care to do that. Nobody's connected her cognitive impairment with the fact that her medication might have been changed. This physiotherapist's home assessment has been done and is in the notes, but it's not in the discharge summary. She goes home, but she's readmitted 11 days later. Very common with older people. Where's the error? Well, there isn't an error. Audit every professional against their own standards, and everybody passes. The failure happened in the spaces between them, and the gaps belong to nobody, unless we deliberately make the spaces between belong to somebody, connect across those boundaries. So we're seeing examples, and I'm sure you're going to be talking about them today, around that holistic care, shared services, shared planning. Several hospitals in the United States run peer safety coaching programs. For example, the New York University Langone Health talks about a pharmacist who spotted a prescribing error and acted on it at 4:30 in the morning while they were on call. At Cincinnati Children's Hospital, they train safety coaches. They don't just include professionals, they do include nurses, but they also include a security guard and an assistant. That's a deliberate decision so that anyone in the organisation can hold safety, can look after that, regardless of professional grade. And notice what made it work. It wasn't a policy, it wasn't a poster, it was coaching. In other words, it was education, delivered in the workplace, working across professional boundaries. And this is what I'm really going to talk about. How do we close the gap? We teach people to close the gap and work in those spaces between. So it's a structural problem, isn't it? Why does it keep happening? Why do we fail patients and their families? It's not a lack of goodwill, is it? It's because of a structural mismatch that runs through health professions education worldwide. We train in parallel. We train medical students with medical students, nurses with nurses. Often they have separate buildings, they have their own curriculum, definitely. They have their own regulators, and they have their own professional identity, which is often formed in isolation as opposed to being formed towards other professions, thinking how the boundaries work. By the time our graduates meet in practice, they've really absorbed those assumptions about the others, and they've never really tested them against reality. I think that's why, certainly in the UK, with our medical education, we have very early clinical contact with multi-professional training, because we can't expect collaboration and integration to happen spontaneously. The third box here, the collaboration here, is treated as a disposition or as a professional attribute, but not really a competence. It's a set of learnable capabilities. We have to learn how to negotiate role boundaries, manage conflict, communicate across professional languages. It is learnable, and it can be taught, and it can be practiced, and it can be assessed. Failing to teach it, failing to assess it is a choice that we often make, because it often falls into the too hard box. So let's think about why this matters. Why is collaborative leadership important then? And what does the evidence show? Huge pressures on all of us right across the world. We face underlying challenge. Aging populations. Taiwan, Japan, Korea, moving to super age status. Older patients, of course, don't just present with a diagnosis, they present with needs, and needs doesn't really respect specialty boundaries, does it? Especially with comorbidities and complexity. So multimorbidity, our models of specialist medicine were designed around single disease, single specialist, or single body system. I think that suited the patient population of the mid-20th century, but it doesn't really meet the needs of the ones that we have now. Workforce strain. We cannot solve a capacity problem by adding people we do not have. And if we have workforce shortages, areas of underrepresentation, underdoctored areas, in my sense, then what we have to do is use the people that we do have better, and use the full scope of every profession. The fourth pressure really is the rising complexity. Complex systems, community, hospital, primary care, social care, family. All those boundaries are a point of potential failure. And I think if the harder we work inside our own profession and we don't address those points of failure, actually that is very exhausting. And what happens is we let patients down. So the other part of that is that how the World Health Organization looks at a health system. It is a set of interdependencies. These are 6 building blocks. Everyone requires leadership across the boundaries. These are interdependencies, aren't they? A failure in workforce really turns into service delivery. You cannot optimize one in isolation. And I think if you're siloed, that does happen. So the service is complex. The second is that leadership and governance is a building block in its own right. The blue box. It's not a wrapper around the others. It's strategic policy frameworks. We need oversight, coalition building, regulation and accountability. Coalition building is collaborative leadership as a core function of the health system. So when we think about medicines, health financing, information systems, and we couple those up with leadership governance and service delivery, what we see is actually we need to collaborate across all of these areas. So collaborative leadership really carries the load there. There is a cost of not collaborating. And again, the WHO looked at patient safety data here. This is the systematic review and meta-analysis from the Annals of Internal Medicine last year. The global burden of unsafe care is massive, and it costs. Around 1 in 10 hospitalized patients experience harm, and at least half of it is preventable. Patient harm from adverse events is likely to be among the 10 leading causes of death and disability worldwide. That's just massive. And all the years lost to disability and death occur in low and middle income countries. When we look at the WHO reports here, we see that global efforts to reduce the burden of patient harm have not achieved substantial change over the past 15 years, despite pioneering work in some settings. 15 years, that's a huge effort, real expertise, but the curve hasn't really moved. So when we think about communication, which I set out here at the bottom, poor communication contributed to a median of 24% of safety incidents and was the sole identified cause in 13.2%. So 1 in 4 of safety incidents involves a communication failure. Not a knowledge failure, it's not a technical failure, it's a failure of information moving between people. For us, that's things like handover, record keeping, just basically communicating in real time. So why has this not happened for 15 years? We've all sorts of things. We've got checklists, handover tools, SBAR, structured briefings. They're all really useful, and we've seen some movements in things, for example, like surgical checklist and the improvement there of adverse incidents. But actually, we haven't seen it across the piece. So the WHO suggests that we need clear policies, organisational leadership capacity, data, skilled professionals, and the involvement of patients and families. And that is a running theme of this conference, which I think is really important. But leadership capacity and leadership of skilled professionals actually needs leadership development and education of professionals. I think what we might have been doing is treating leadership problem as a technical problem rather than an adaptive problem. And we need adaptive leadership for complex situations. So we have some definitions. I've been talking about these things, but these really come from the WHO Framework for Action. This was in 2010, so we have got that sort of 16-year window, but it's still an international reference point. For those of us who work in interprofessional education like I do, it was such a seminal moment. And I was working in New Zealand at the time, and we did a lot of work in New Zealand around interprofessional education, interprofessional learning. Interprofessional education is about when students or members of 2 or more professions learn about, from, and with each other to enable effective collaboration. And that does improve health outcomes and services. So it's purposeful collaboration, isn't it? We want a collaborative practice-ready health worker. This is somebody who's learned to work in an interprofessional team and is competent to do so. Again, New Zealand, we developed, I led a project at Auckland University where we developed interprofessional competencies, which we embedded in our curricula all the way through pharmacists, public health, undergraduates, nurses, and medical students. And that was a really interesting piece of work. And I think helped those students become more collaborative. And that then leads on to collaborative practice. So this is where health workers from different professional backgrounds work with patients, families, carers, and communities to deliver that highest quality of care. And this is a sequence. It's a causal chain. Our education leads to our practice-ready workforce. It leads to collaborative practice, and it improves the quality of care. So education is fundamental. I think I would say that. So when we're thinking about the about, with, and from in interprofessional education, really, really important. Learning about other professions is easiest. It's necessary so that we know, what a physiotherapist does, what an endocrinologist does, what a occupational therapist does. We need to know that. We don't want ignorance about what other colleagues are trained to do, but it's the shallowest level, and you can read about it. Learning from goes further. This is learning about learning from other professionals, from their expertise. You're using somebody as a source of knowledge that you do not have. And this begins to disrupt the hierarchy, particularly when we think about perhaps the doctor-nurse hierarchy, which is one of our fundamental ones. Actually, experienced nurses know an awful lot, and doctors have their own role, but we have to learn from. Because that means that we're listening to other people as experts. And nurses, particularly in the hospitals, are often the experts about the day-to-day patient life. And then the final one is learning with. This is learning on shared tasks, learning together. And this is where professional identity gets sort of renegotiated a little bit. This is where the real work happens. It's not learning sitting in a lecture theatre here having a lecture on diabetes. It's actually working on tasks together so that you're really thinking, oh, that's what a pharmacist does. That's the expertise that person brings to the table. So when you're thinking about your learning, think about, is it dependent on the presence of other professionals? If it isn't, you've shared a lecture theatre, you haven't built collaborative capability. So let's not waste those moments where we do actually bring our learners together. So what does collaborative practice deliver then? We've got lots of evidence here, remarkably consistent right across different settings. For patients, we see higher satisfaction, better acceptance of care, better adherence to treatment, improved health outcomes, better access to and coordination of services, fewer complications, and reduced mortality. So that's really good for patients. But it also helps the systems because financially people aren't coming back into the system like our patient example did earlier on. So for systems, we're seeing increased safety, fewer clinical errors, much more appropriate use of specialist resources, reduced length of stay and admissions, and a reduction in the cost. Well, that's really helpful. We have to have an efficient service. And for staff, it's really important. It isn't an additional demand. What it does is actually improves well-being, staff turnover, builds stronger professional relationships, and actually really reduces isolation, distributes emotional load, and actually gives meaning to your work. So there are benefits. So let's think about the leadership piece next. What is it? It's different from collaborative leadership is different from teamwork. It's different from consensus, and it's certainly not just being nice to one another. There's a lot more to it than that. And what we've seen with leadership over the last, I would say, 15, 20 years, fundamental shift in how we understand it. That traditional look of leadership, individual, hero leaders, hierarchically based, linked to position. But on the right, we see it's much more a property of social systems. It can be at all levels. It's not just leaders doing things to followers, but followers actually co-creating things with leaders. The context of leadership is crucial, and we can learn leadership. And what we see is instead of leaders holding the power, power is dispersed across the system. So it's not just a progressive, shift here. I think sometimes we need that sort of leadership in the situation. For example, if you've got a cardiac arrest or an emergency, you want clear leadership. You don't want to be sitting around chatting about how things might be done, What you need to think about is, let's get this patient assessed, seen, treated, made well, hopefully. So in the UK, our General Medical Council says that, whilst the leader's the one who's accountable, okay, that's often the clinician, the physician, the responsibility for outcomes is shared. And this is much more than simple semantics. So hierarchy isn't always wrong. It's that many of our systems default to hierarchy where it's actually harmful. The skill is knowing what sort of leadership to adopt in what situation you're in. So the heroic model is still super powerful, isn't it, in healthcare and particularly in medicine? Where is it found? The heroic leader, the authoritarian leader, often at the top of the organization, but shared leadership is dispersed. It's distributed throughout and across organizations. Sharing power can be really difficult. Talking about how decisions are made. You've got a session in the conference where you're talking about shared decision making, really shifting away from that, heroic, all-knowing expert and shared by those who actually understand it. And that absolutely includes the patient as expert. Also thinking about the power, how we can give power, how we can disperse power, how we can share the power that we have. That's really powerful. We talk in education about empowerment, and that's what empowerment is. It's giving some of our power away. And in collaborative practice, we say that the more power we share, the more power we have to use. And that's the essence of collaboration. So change can be dispersed through development, innovation, co-production. And then I think the rewards are really interesting. Who gets rewarded or acknowledged for things that go really well? Is it the leaders and senior management, or actually is it all those who contribute to improvement? And this is a really good set of questions to look at and look at your own organisation, your own department, or your own practice. So we have three related but distinct concepts, don't we? We have that collaboration. It's a philosophical and cultural commitment to working in the shared interests of better outcomes. It can be informal, it can be quite fluid. It involves joint decision-making and collective responsibility. Partnership is a little bit different. It's usually a formal agreement with explicit governance. You can have collaboration without partnership, and you can certainly have partnership without collaboration. You might have a signed memorandum of agreement with another organisation, but you don't genuinely collaborate. Co-production goes further. That's about patients and communities as genuine co-designers whose lived experience is essential to service design. So co-production that is tokenistic, that brings people in without giving them influence, doesn't just fail, actually damages trust, and it's worse than not asking people to get involved at all. So that's really important, isn't it? To think about what we're doing and what we want. And if we're going to co-produce or engage or have shared decision-making, genuinely we have to do it. I think this is quite an interesting contribution, actually. This comes from military strategy. This is the General Stanley McChrystal's concept of teams of teams. And I really like this. He observed that a hierarchical command structure was really optimized for efficiency and predictability, but in a complex networked environment, which our health and care sectors are, is not actually as useful. And he said, let's have multiple high-performing teams, small teams, but they're connected by a shared consciousness. They're connected by empowered execution, by cross-team trust, and by what we call gardener leadership, is nurturing. So we create the conditions for those teams to function, not directing the outcomes. It's a little bit different. but it does help us with healthcare's real problem. Our individual teams are usually really good. It's the connections between them that fail. If you look at incident reports, root cause analysis, what you will see is the failure lives in the gap between the teams. It's not usually inside the team. What's really important then is how do we work in the spaces between? We call those liminal spaces, the spaces between organizations, between teams, between departments. We have three roles, and I think leadership, we really can take this to us as leadership. We have to bridge, create a route between groups that don't have that bridge, making connections possible. Connecting people up is so important there. So the bridging is important. The second piece of work is brokering. This is negotiating between parties with different interests. Sometimes we have to translate the language, the jargon, the outcomes, because they don't belong to one or the other. And those boundary spanning leadership is really important. Working across boundaries, thinking about how do we engage with community care, third sector, public sector, industry. How do we bring all those people together? I think in most organizations, the people that do this, it's not really written into your job descriptions. It's doing it that because you see its importance as a leader, and it's very fixable. And so thinking about the spaces rather than the things like the departments or the teams is really interesting conceptually. And this brings me on to a model that I'm in the middle of developing, which is about working in the spaces between, but also making sure that the work happens in your teams or your areas. And this is called the boundary leadership model. What we have here, it's got two catchphrases. I'm sharing it with you for the first time. I was thinking about how do we lead from the middle of systems rather than from the top? And in interprofessional healthcare, that's most of us. We rarely have formal authority over everybody we need to influence, and we work across boundaries. The signature line here is firm inward. What does firm inward mean? Clarity about your own values, your own purpose, and your own limits. It's really about your authority being consistent, it's grounded, and it allows you to be adaptable and a bit fluid, but you're not going to be destabilized because you're sure of your authentic core. Fluid outward means permeability at the boundaries. Thinking about those liminal spaces, don't just cross them. So we've got boundary literacy. We need to understand what the boundaries are and why they're there. We need to think about the levels of the boundaries, particularly up hierarchical systems. So if we do that, and if we're having professional working, then actually that fits, doesn't it? We have our own professional identity securely, but we can remain genuinely open to being changed because our authentic core is not going to change. That is us, and it's about us, and we can be fluid out there. So that idea of boundary literacy is the heart of the model, is that it's a meta competence. It underpins the other capabilities. And what I've thought about is it's got these different elements. We need to read that a boundary is present. Nobody names boundaries. We often don't do that. People attribute failures or errors to personality, but actually it's that you're standing either side of an unspoken professional boundary and you don't talk about it. Then we need to recognize what sort of boundary it is. Is it professional scope? Is it organizational accountability? Is it cultural difference? Is it hierarchy? We need different responses for those. And then we need to respond to that. We need to hold it, soften it, cross it or dissolve it. They're not obstacles by default. And at the bottom here, the key distinction, a generative boundary creates a productive edge. And this is very much about change, emergent change. If we can think about that, if we see them as barriers rather than boundaries, we are not going to cross those barriers or we're going to crash into them. But if we see them as boundaries where we can actually learn, work together and understand, then actually what we'll do is deliver that holistic care. So let me come on to the third part there. Collaborative leadership really, really requires a commitment to holistic care. And let's connect this to the symposium. So no single profession holds the whole person, the whole patient, do they? We have the different elements here. We have the physician, the nurse, the pharmacist, therapist, social worker, patient and family, many more professions we could add into that. But each profession has a perspective on care, otherwise they would not be separate professions. And so we see that, and I think what we have to think about, that these are all partial views, also they're all correct, not is a lesser view, and what we're trying to do is bring all the parts together. So holistic care is not about one profession or one senior person seeing more than the others. It's the integration of perspectives, multidisciplinary case conferences, multidisciplinary ward rounds, board rounds. These are where the good leader actually asks for all those perspectives, and through that we form a picture. And so handover shouldn't be one directional. You should be inclusive. And it's difficult when we're busy and service is busy, but if we don't do it, it's not going to be very holistic. So however well-intentioned everybody is, that care isn't going to be holistic. And of course, at the center of this is the patient and the family. The patient is not an object of collaboration. We really have to include them as a team. They are the expert in how their condition affects them. Okay, you might be an expert on strokes or diabetes or whatever, but actually they know how that stroke is affecting them, how that diabetes is affecting them. So shared decision making is really important, and you're talking about that next. It's collaborative practice at the bedside. Same competencies, same power dynamics, and the same risk of tokenism if we're not careful. And the evidence on power is really uncomfortable. Professionals carry institutional, professional, cultural power that can marginalise the patient voice, even in initiatives designed to amplify it. And thinking about cultural specificity, again, I'm outside your context, you're the experts in your culture, but actually the difference between Asian cultures and, say, in the UK or Western cultures is the individualist versus the community, and where the patient and the family sits there. So thinking about what is the collaborative unit, it might be the family, it might be the individuals, it might be the couple, whatever it is. And I think you need to we all need to contextualize that. Also, you can't, this is about well-being as well. It's a bit of a diversion, but I feel really it's so important that making sure that we look after our teams, we look after our leaders. For example, doctors who experience poor well-being are at much higher risk of clinical error. Weston Coyer talks about this, and of leaving the profession. So well-being is a patient safety issue. And that look of compassionate leadership really thinks about attending, understanding, empathizing, and helping. Compassionate leadership isn't about being nice to everybody. It's about putting care into practice. So really, the other thing I would say is beware this resilience narrative. There's been a huge emphasis, and I think we're shifting off this a little bit now, but resilience really has to be thought about as adaptation, not a performance requirement. We often try and select our medical students, for example, because they're resilient. Actually, what we want is grit. We want that passion and perseverance for long-term goals, not that somebody can be like solid, whatever happens to them. And as educators and as leaders, we have to look after our team. So education is the mechanism, and really, as leaders, we create the conditions, but education creates the capabilities and the capacity for people to actually do what we want them to do. And so they need to be seen hand in hand. Interprofessional education is a continuum. It's not a one-off at all. And I think if we think of the 4 areas, really thinking about pre-qualification at undergraduate level, then in transition to practice, the internship for our medical students or nurses, but actually that early career, very anxious time in the workplace, and then continuing development. So we have to think about producing and educating interprofessionally all the way through the continuum of education. So how do we make it happen? It's a huge gap between the concept of interprofessional education or interprofessional learning and actually making it happen. And these 6 elements here are really important. You need to fix the timetable and the funding. Most interprofessional learning fails on the logistics of actually getting people together in the same place. So aligning them across different faculties is a leadership decision. We had a really good example in Auckland University where we had a week of interprofessional learning that all the undergraduates did across the faculty, different professions, working to learn about Maori and Pacifica health. And that was a really fantastic week. I've never seen anything quite so good. It was a privilege to be involved. Faculty development, prepare your teachers, educate people to teach in an interprofessional way. Build psychological safety, enable people to speak up across hierarchy. That can be very difficult. Use accreditation and regulation. Our General Medical Council in the UK now requires us to actually look and report on interprofessional education. Oh, that's a good lever for me as a dean. Assessing collaborative competence and model it visibly. If you don't model it as a leader, other people aren't going to do it. And so there's a really hard set of challenges under here. And I want to talk about it because it really impedes. We have to think about roles changing, extended roles of practice, extended scope. We've got prescribing pharmacists, nurse leaders, advanced practitioners, community health workers. We have to trust that other professionals can do the job. It can feel like a loss when we're losing our role boundaries and feels like it's giving it away. But actually, we need to work with that as leaders. It has to be trustful. We have to trust that other people can do that, but we also have systems in place and checks and balances. So really thinking about that, I've certainly seen with some of our junior doctors in the UK, when the physicians associates came, that felt like a huge challenge to that role because the physicians associates were doing quite a lot of the jobs that the junior doctors would do. So that had to be put in place in a system perspective. Patients don't really think about the different professions and what they give. What they feel like is what's the experience of being a patient in this context, and they want the best care. They don't always mind who gives it them. Although some people, there is status and hierarchy, but that's important. So these are my frameworks that I use in my own teaching. This is the 5 C's of healthcare leadership as we move towards the close here. Comfortable with conflict. We really have to enable conflict, to diffuse it if we can, and to be comfortable there. We don't avoid it. Or suppress it. We have to, false harmony is not helpful, to be honest. We need to be caring and compassionate with our people, with our followers, but also it's role modeling as well, isn't it? Co-production and co-design, that's our 3rd C. Patients and communities as partners in designing care, not just recipients of it. Collaborative and collective, leadership's a property of the system distributed to where the expertise and knowledge actually are. And then the final thing is we need to have what Obolensky calls cognitive complexity, holding several partial truths at once without collapsing them into one. That is really difficult. And it's the same thing as boundary literacy. It's actually being able to go, oh yeah, of course the nurse said this and the pharmacist said this, or, from that department we can have this and from that we can have the other. Our choice is to really hold those together so that we can actually make some decisions. So Monday morning, it might not have to be Monday morning, but these are things that I just thought you might want to think about. And it's sort of things that you might actually do. Think about one boundary that you have been treating as a barrier. Think about a relationship between 2 teams or professions where things often go wrong. What boundary is it? What is going on in the space? Has anybody actually spoken about that? Why is it a barrier? The other thing is, and if it's not yourself, who are bridging and brokering? Who are your boundary spanning leaders? Let's actually acknowledge that. Let's look at that important work about joining those connections up. I absolutely value when I'm in an organisation, knowing the people who knows who I can contact to do that and who does the things in the spaces. And that, as you know, as a new dean who's only been in post for 4 months, that's super important for me that I know some people that do this work. And then when you think about your assessment or your curriculum or your appraisal, do we reward collaborative competence? If we don't, then that might be one of your answers about why it's not happening. None of these things to do require restructures or new money. It's a way of thinking. So just to sort of bring this to a close, I described a patient where everybody did their job well, care was still not holistic. And then we talked about, you know, somebody at 4:30 in the morning picked up something that nobody else had. The difference is really about creating the conditions for the gap to be closed. So holistic care is not a philosophy. It actually is an achievement, but it does involve a mindset of leadership and professionals who are prepared to work together. And our leadership has to create the conditions in which that becomes possible and acknowledges and rewards the fact that people do work together rather than working in silos. And I'll just leave you with the phrase that really sort of anchors the boundary setting leadership. Be firm inward, be clear about who you are and what you stand for, your why. Simon Sinek calls it your why. And be genuinely permeable and fluid at the edges, really think about it. So I hope this has given you something to think about, some frameworks. You can have the PowerPoint presentation to look at, and there's a lot of detail in there. But congratulations to Tri-Service General Hospital. Congratulations on you all on your 80 years. And thank you very much for having me. The final slide has some reference sources on it. So for those of you who like the evidence, I do certainly. But I will stop there and thank you very much.
Thank you, Professor McKean, for sharing this wonderful video with us. Next, let's welcome our moderator, Professor Jian Zhichen, Superintendent of Cathay General Hospital, to introduce our second speaker. Welcome.
Okay, we think we enjoy the speech so much from Dr. McKean. And now it's my honor to present you our next speaker. This is Professor Huang Xianye. Professor Huang is currently the chief of the Division of Palliative Care and Medical Education, Medical Humanities at the Department of Family Medicine, National Taiwan University Hospital. As a leading figure in interprofessional education, that's IPE, he deeply values cross-field collaboration among doctors, nurses, and pharmacists. Dr. Huang brings a wealth of expertise in clinical ethics, symptom management for terminally ill patients, and interprofessional team education. Today, he will present us the topic of blueprint for holistic care, enhancing early palliative care, integrating through shared decision-making. So let's sit back and please join me in giving a warm welcome to Dr. Huang.
Thank you, Superintendent Professor Jian and Professor Tsai and all the distinguished professors and speakers and the audience. It's really my honor to be here to celebrate the 80th anniversary of Tri-Service General Hospital. And I'm Dr. Xianliang Huang, and I'm from or you can call me Solomon, King of Wisdom. So I'm from National Taiwan University Hospital, and also in this year we just built up a Center for Integration of Supportive, Palliative, and Innovative Research and Education Center. You can call it Inspire Center, because each year our hospital will choose 5 domains that probably to become the HR #1 center. So we are very honored to have this chance. And so today's my topic is about a blueprint for holistic care, enhancing early palliative care, integration through shared decision making. And this is the logo of our Inspire Center. And but before my topic, I want to share with you just a cute story. Because in this morning, I just drive my daughter, who is in the 9th grade of junior high school. And I told her that I will go to Tri-Service General Hospital for a talk. Then she told me, oh, you will face many soldiers and generals, so you shouldn't be late. You just go directly. So I just dropped her and drive directly to Tri-Service General Hospital. So I arrived 1 hour earlier than the speech time. And at the front door, it is really a soldier welcome me. So I think I will thank my daughter, that thank for her advice that I arrived very correctly. Next slide. Should I control by myself? Oh, okay. This is my conflict of interest disclosure, that I had no conflict of interest to disclose. But I used ChatGPT to assist with grammatical correction and improvement, and also for the enhance the clarity and the organization of the presentation slides. And I found that my style of slides is a little bit like Professor McKean. So maybe we trained our GPT in a similar way. And we had a similar style for the PowerPoint. So that you can find that my style is a little like Professor McKean. So today, this is my outline. First is I want to introduce you why holistic care is very similar to palliative care, because we both care for whole person and the family. And the second is I want to introduce you about shared decision making, why it matters to bringing together the holistic care and palliative care. And next part is I want to introduce you the SOP model, that our team built this model for early integration of palliative care in past years, and with series of publications. And I will introduce you with some of these important results. First, holistic care addresses whole person suffering. When a patient has serious illnesses, the patient would have many physical symptoms such as pain, breathlessness, and fatigue. Also, they will feel fear, anxiety, depression, and their family also encountered this very stressful condition, much care burden. Also, the patient would have some spiritual distress. They would think, what is life meaning? Where is the hope? And can they find the dignity in his or her life? So palliative care is the holistic care in action, because we relieve physical, psychological, social, and spiritual suffering. And we support patients and the families. And we use this an interdisciplinary team, just as Professor McKean introduction. We include physicians, nurses, social workers, clinical psychologists, even nutritionists, and rehab specialists. We protect quality of life and dignity. And why early integration matters? Because in traditional model, palliative care always introduced late in the disease course, usually after the treatment failure. However, in current model, also the WHO suggestion that we should integrate earlier alongside with curative treatment. Then we will help the patient to have earlier symptom support, try to help them for advanced care planning, and will give better caregiver support. Any evidence already support early palliative care. The most renowned paper is from Timel and colleagues in 2010, published in NEJM for non-small cell lung cancer patients. The early integration of palliative care increased the quality of life, decreased depression, and decreased aggressive care at the end of life. And furthermore, surprisingly, the early integration of palliative care also prolonged the survival for several months. And Lieberman et al. In 2014 published in Lancet a randomized controlled trial also showed that early integration of palliative care increased quality of life and increased overall satisfaction. And from the Cochrane review in 2017, quality of life increased and the symptom burden decreased. So early palliative care is really an important part for holistic care. Next, I want to introduce you why shared decision making is important for holistic care. From the AHRQ, the Agency for Healthcare Research and Quality, the definition of shared decision making is a collaborative process. And it's a collaboration between patients, families, and medical professionals. So I would like to think it as a combination of three key elements. The first element is evidence. Patients and families need to understand what will happen after each treatment options. And our professionals should, based on our clinical expertise, we would understand what is medically reasonable for the specific patient. And the last, but probably the most important, is the patient's perspective. And in our Taiwanese culture, family's perspective is also very important. What matters most to the patient and the family? So the goal of shared decision making is not to choose a medically best. It's the goal to choose what suits most best to the patient and the family. And this is the shared approach from HRQ for SDM process. First, we seek patients' participation, help patients explore and compare treatment options, and assess your patient's values and preferences, and reach a decision. Then evaluate the patient's decision. And this figure is the basis of our SOP model, so I will try to introduce you more. This is from the Professor Elwin. They published similar paper in 2012 in JGI, Journal of General Internal Medicine, and also in 2017, and recently also another important paper. And they consider that SDM is a process of deliberation. And the process of shared decision-making brings with, because when a patient comes to your clinic, they had some initial preferences, but it's always sometimes based on just incomplete information. So through shared decision-making, the first step is choice talk. We should let the patients and the families understand and recognize every possible treatment options. And during the option talk, we use decision support to help them understand the benefits, the harms, and the trade-offs of each treatment options. And after the process, patients would have had some informed preferences. They understand the benefits and the risk. Then we help them to discover what matters most to them and reach a decision that is suitable for their values and perspectives. So we integrate this process of STM into our early integration model. So why STM matters? Because prognosis is often uncertain, several reasonable options may exist, benefits must be weighed against burden because these patients are very weak. And the family and the culture shape the preferences together. So we developed this SOP model, shared decision-making with oncologists and palliative care specialists. We developed this model for patients with advanced cancer early in the course, just after the diagnosis. And we link oncology, case management, and palliative care together. We support care alongside with active treatment. And this is the original paper first published in BMC Palliative Care in 2020. And it's the SOP model for the advanced cancer patients for do not resuscitate and the preference of artificial nutrition and hydration in an outpatient clinic setting. So this is the framework that the oncologists conduct the choice talk first, and then the case management alongside with our palliative care team had an option talk with the patient. Then our palliative care specialists would explore what patients matters most during the decision talk and reach the end-of-life care preferences. So this is the SOP clinical pathway. During choice talk, the oncologist would introduce options and invite patients' participation. But because oncologists are too busy, so now we will, our case managers and the palliative care shared care nurses will join together for the option talk, compare care pathways using a decision aid. And our palliative care specialists would clarify the values and plan out next steps. So in this first study that we, there were 375 eligible patients, and finally there were 255 participants joined the study, and the mean age was 68.5, and the study period is 2016 to 2018. I think this is the most important figure that when the patients are in the oncology clinic, no patients had signed do not resuscitate order, even they just understand the diagnosis of a very advanced cancer. But after the option talk, there were 44% patients signed the do not resuscitate order. And in the end, when they visit the palliative care specialist after the decision talk, 80% of the patients already document the do not resuscitate order. However, when it comes to the preference of artificial nutrition and hydration, which is a very ethically complicated problem, few patients had already understand their preference even after the decision talk. So at the same time, those patients who do not join this SOP model just had 52.3% documented the do not resuscitate order, even in the end of life. But in the SOP model, already 80.9% patients documented do not resuscitate order just after the SOP model. So I think we try to help patients and the families express their values earlier in the disease course. So lessons from our first SOP model is that patients can discuss future care before any clinical crisis happen. And oncology and palliative care roles are complementary. I think that just can go back to Professor McKean's suggestion that we should broaden the boundaries. We are together. And some decisions require time and repeated dialogue, just as the preference for artificial nutrition and hydration. And documentation is just one part, so we need to have a longer follow-up. So this is the second research that we implied this SOP model in advanced pancreatic cancer patients. We all understand that pancreatic cancer usually be diagnosed late and have a very poor outcome. So pancreatic cancer usually rapid progression, high symptom burden, dyspnea, pain, malignant bowel obstruction. All these symptoms cause patient very suffering. So, but palliative care often introduced too late. In previous experience, almost just several days before death. So I think it's really too late. So we enrolled 137 patients with stage 3 to 4 disease that is unresectable. And we compare the SOP model with usual care for them. We try to understand could structured SDM improve palliative care acceptance. This is the framework that when a patient diagnosed for have advanced pancreatic cancer, we integrate with SOP model and help the patients receive interdisciplinary and early supportive care alongside with cancer-directed treatment. And we hope to help patients get co-concordant outcome. I think this is the important figure that the patient, this bar is those under usual care in the year of 2018, and we introduced the SOP model in the year of 2019 and do the historical cohort comparison. And after the initiation of SOP model, there are about 78% of patients received early palliative care. And compared to usual care, only 50% of patients received palliative care before death. However, for these medical resources outcome, such as the hospital admissions, ER visits, ICU treatment, 3 months before death, there was no difference found. So in this second study that we found that palliative care acceptance increased dramatically after the initiation of SOP model. So in our hospital, we try to implement this SOP process for every advanced pancreatic cancer early in the disease trajectory. And after several years, I think this is the last year's publication, and it's very important because it's published in JAMA Network Open, and we implement the SOP model in oral cavity cancer. Because we all understand that advanced oral cavity cancer patients, I think in this, every clinician would understand that the huge tumor on the face or in the neck cause very severe symptoms. The function, such as speech function, swallowing function, the nutrition would be very poor, and also had many symptoms such as pain. And these patients not just had a tumor pain, but also neurological pain, and fatigue, and they also had many airway symptoms, airway obstruction, much airway secretions, and also there's a whole person impact. Because the image is impacted, they had social isolation. They didn't want to go outside to meet with people and their friends. They will have much distress. So we implement the SOP model in these patients, want to help them earlier in the disease course. So the same, we try to implement SOP model when the patient just diagnosis of advanced oral cavity cancer, still help them to receive multidisciplinary palliative care alongside with cancer-directed treatment. We enrolled 430 patients with stage 4 oral cavity cancer patients. And in the year 2018 to 2019, there were 229 patients. And in the year of 2020 to 2021, there were 201 patients. And in the year of 2020 to 2021, this patient received SOP model. And these patients were under usual care only. And some patients still got cured. So we should say that the treatment for oral cavity cancer really advanced much. And so this is a very important opinion that palliative care is not just for incurable patients. We introduced earlier in the course, even they had a chance of cure. So we still bring help, bring the holistic care to those patients who might be cured, but they face very serious illness. So enter the final analysis. There were 58 patients received usual care, and 52 patients received the SOP model. And this is the table that shows some important outcomes. I just want to highlight two important outcomes. Is that the patients who receive multidisciplinary palliative care consultations, in the SOP model, there were significantly more patients received these consultations. And among the medical resources utilization, only the hospital admissions 3 months before death were reduced. And this is used a linear regression model. So the beta efficient is positive, then means more consultations. So more multidisciplinary care were received, means that these patients receive more palliative care consultations, more access to social worker, clinical psychologist, spiritual, and the rehabilitation support, and fewer hospital admissions in the final 3 months. So what the SOP program shows, a structured SDM model helped advanced cancer patients documented their preferences and help pancreatic cancer patients, oral cavity cancer patients receive more palliative care before death. And last, I want to introduce how these 3 steps help patients and families. The choice talk opens the door earlier. We present palliative care alongside with other cancer treatment options. Then the patient would not feel abandoned. It's just a common integration through the usual cancer care. And explain the choices exist, and we invite the patient and the family participation, and offer their chance and the referral for deeper discussion. And during the option talk, we make trade-off visible. We check the understanding of illnesses, explore symptoms and the treatment burden, and compare benefits, harms, and uncertainty. We use a patient decision aid. And the goal is the understanding. We just let them understand what is treatment option and what is palliative care. We are not persuading them. We are not just telling them, no, you should go to palliative care. We just let them understand there is a choice. Then they will think by themselves. And the final decision talk turns values into a care plan. Our palliative care specialists ask them what matters most and clarify the acceptable treatment burden. Of course, currently there were many anti-cancer treatments, but some of them are very expensive. Some families, major problem, major barrier is the financial barriers. So we need to clarify the acceptable treatment burden and include family without replacing the patient voice. They are a whole family, a whole person, whole family care, and decide, defer, or revisit. So the outcome is a reviewable, goal-concordant care plan. Okay, then that's my final take-home message. Holistic care sees the whole person, and palliative care relieves multidimensional sufferings. And our SDM reveals what matters most. And SOP model makes early integration implantable. So shared decision-making is the bridge to early holistic palliative care. And I think it's really corresponding well to today's theme. And that's my talk. Thank you very much.
Thank you, Dr. Huang, for your insightful presentation on holistic care and shared decision-making. I would like to have our moderator to give out some kind words.
Okay, thank you so much for your inspiring talk. Personally, I enjoy your talk so much because I have some memories about my dear friends and my families, my relatives. I remember what kind of their life and the end stage of their life, and it's quite a different story about yours, about what you mentioned. So I think you are doing, and you and your team are doing a great job helping those people and as well as their families. Is that possible? Can we take some questions from the crowd? Okay, great. Any questions? Great, please.
And congratulations first for the great job. And I just wondering, I look at the data from the otolaryngeal cancer care patients that the study published on the JAMA Open network. And I noticed there's over half of the patient eventually they cured, right? So I just very curious about those patients who enter the SOP model and not in the usual care model. Is there any difference for their satisfaction and in terms of the quality of life and care? Have any analysis for those part of patients? Because you exclude those patients from your study, right? Yeah.
Thank you, Professor Wu. Because this is historical design comparison. So those patients in 2018 to 2019 just received usual care and only followed by the case managers without our palliative care team. So these case managers would still follow up for these patients. But I just have very few evidence that the follow-up call of these patients without SOP model, the case management said that they still had high satisfaction with the treatment. Yeah. So the patient satisfaction is still high among those patients without SOP model. But not just the random sampling. I think maybe just 10% of the patients had been surveyed. Thank you.
Okay. Any further questions? Yes, please.
Thanks for your speech, Professor Hong. And I have one question is about the practical practice in the shared decision making. Because in Taiwan reality, our patients see so much in our each clinical sessions. So I would wonder the procedure, how you perform the SOP model in your daily practice. Does it really, I think it's really time consuming. So I'm really curious about it. Thank you.
Thank you for this very important question. I also present this in the European Association of Palliative Care, and they also asked me the same questions. Because so we didn't want to consume oncologist or otolaryngologist time. So they just introduced that we had several treatment options. A, B, C, and D is palliative care. And later, our case managers will introduce you more. So they just leave the clinic, leave the busy clinic, and enter to another conference room, another talk room, and that is choice talk. Then the option talk, who needs more time for deliberation, is by case manager and our shared care nurse. They will, in the otolaryngology outpatient clinic, another room, and have a detailed discussion with the patient and family. So the oncologist or otolaryngologist didn't need to spend much time on explaining this. Yeah, that's our clinical pathway.
Okay, great. Yes, the time is up sign is already there, so I have to close this section. Let's give a big applause to Professor Huang for his wonderful speech. Thank you.
Okay, thank you for the question and comment. Now, On behalf of the organizing committee, it is my honor to invite our moderator, Professor Jian, to present a certificate appreciation to Dr. Huang. Professor Jian and Dr. Huang, please move to the front of the stage. We will take a photo now. Please face the camera and smile. Thank you, Professor Jian and Dr. Huang. Please return to your seat. This concludes the first part of the session. The next session will begin at 10:40. Please return to your seats before the session resumes. A bell will ring 5 minutes beforehand. We now invite you to take a short break. Refreshments are available outside the conference hall. Thank you. 现在进入休息时间。下一场预计于10点40分开始，敬请各位长官及贵宾10点35分前返回会场。会场外备有茶点，敬请享用，谢谢。 Ladies and gentlemen, the second session will start shortly. Please take your seats and kindly ensure that your mobile phones are turned off or switched to silent mode. Thank you. 各位长官及贵宾，第二阶段会议即将开始，敬请各位贵宾准备入席，并将手机关闭或调整为静音模式。谢谢。Ladies and gentlemen, welcome back to the International Symposium on Holistic Care and Healthcare Quality 2026. Now, let us welcome our moderator, Deputy Director for Medical Affairs, Professor Wang Yuqi of Tri-Service General Hospital, to introduce our speaker. Professor Wang, please.
Good morning, ladies and gentlemen. So it's my great pleasure to introduce our speaker, Professor Celestial Ye. Okay, Professor Ye received her MBBS from Singapore and PhD from the University of Edinburgh. She currently serves as the Physiology Program Director for Health Professions at the National University of Singapore and as the medical science lead for the respiratory system and multi-system block, where she helps integrate medical science with clinical practice in medical education. And in addition, she is also the principal investigator of the cytoskeleton and tumor biology laboratory at the NUS Center for Cancer Research. With her diverse experience in education, research, and medicine, Professor Yue is dedicated to building a culture of holistic professionalism and well-being through an integrative approach to health. Today, she will give us the talk entitled Shaping the Future of the Health Professions Community Through Well-Being. So let's welcome Professor Ye.
Thank you very much, Professor Wang, for your kind introduction. And good morning to everyone. Congratulations on the 80th anniversary of the Tri-Service General Hospital. I'm very pleased to be here, to be meeting colleagues and friends from abroad as well as from Taiwan. And I'm going to be talking about shaping the future of the health professions community through well-being. And I'd like to invite everyone, first of all, to fly with me to Singapore and walk through our Singapore Botanic Gardens as the first step towards well-being. But for me, in the past few days, I think I've explored a little bit of Taiwan. And well-being for me was looking out at the scenery at Jiufen. And this was just after the typhoon had just passed. So that is my personal well-being trip in the last few days. But let's look at what the World Health Organization says about well-being. It's a positive state which is experienced by individuals and societies. It is similar to health and is definitely important for daily life. And there are various conditions that determine this, as we've heard this morning: individual, social, economic, and environmental conditions. It encompasses both the quality of life and, importantly, allows people and societies to contribute to the world with a sense of meaning and purpose. And again, this morning we have heard how meaning and purpose is so important to all our work and for us to live meaningfully. And when we focus on well-being, we then think about how we distribute the resources, how we can thrive as a community and sustain the overall well-being, and hopefully that we can also be resilient and build capacity for action so that we can transcend the various challenges. And I think all these statements are just so pertinent also to the health professions. What is mental health? Mental health being a really crucial component of us in well-being. And this cartoon here shows a hippo taking a dip at the end of the day in his favorite river, unfortunately being rained on by the elephant and also maybe having to give up his seat to the crocodile. Nonetheless, he may still be experiencing well-being and mental health, good mental health, because it is actually the state of well-being, what is mental health, in which an individual realizes his or her own abilities and, in spite of stresses in life, can cope, work productively, and contribute to the community. And importantly, World Health Organization also recognizes that mental health is not just the absence of mental disorders. So it is not a state where we are not diagnosed with mental disorders, but really it is something that's fundamental to our daily living and our quality of life. So what factors impact mental health in a healthcare setting? Multiple factors: biological, psychosocial, and workplace. First of all, healthcare workers face a lot of physical and mental fatigue, long work hours, working shifts, a lot of demands, wearing many hats. And there is also a component called compassion fatigue, whereby we give so much of ourselves, caring for patients, their relatives, even caring for colleagues, that we get tired of really caring. And don't forget that there is actually daily psychological strain, because it is not really normal for human beings to be exposed to suffering and sometimes even death on an almost daily basis. And these are all the burdens that healthcare professionals have to carry. And in addition to that, our professional expectations and obligations often mean that there is no room for errors. We have to be perfect in what we do as we carry on our multiple roles and responsibilities. There are also evolving cultures and expectations, new technology, some of which can be helpful, like AI, some which may not be, with adds additional burden to us, like excessive documentation, complex systems, processes, and then having to actually balance the thought of How expensive is this? How much is this going to cost to the patient, the system, and how much would that benefit to the patient? So all these are really, there's a lot of unpredictability in the system. But really, something which is highly important and contributes to poor mental health in healthcare settings is also the fact that there is stigma in healthcare workers in reaching out for help. So quite often, healthcare workers would actually seek help only when they are truly terribly exhausted or burnt out, but they may not seek help in a preemptive sense. And this is one of the major considerations that we need to take into account when we try to build systems and try to enable people to look after their mental well-being. So what is the global experience of burnout? It's widely reported across all the disciplines in healthcare, doctors, nurses, allied health professionals, educators, and administrators. And in 2019, the National Academy of Medicine in the US reported that burnout had reached crisis levels. Look at the percentage. More than 50% of nurses and physicians facing burnout. And more than 50% of even medical students and residents face burnout. And this was pre-pandemic. And what happened during pandemic was basically that across the board, all the public health workers reported several symptoms of mental health conditions, anxiety, depression, post-traumatic stress disorder, and even suicidal ideation. What is the World Health Organization finding? During pandemic, at least a quarter of healthcare workers reported these symptoms as well, and this is a little bit more global finding. But I think what we need to ponder about is that even after the pandemic had left us, there were no significant reductions since then. And this is our experience in Singapore, published again a few years ago, 2022, showing that the prevalence of burnout among healthcare professionals in Singapore is also really high. There were 6,000 of the professionals surveyed. More than a third had high emotional exhaustion. Almost a third had high depersonalization, which is basically the sense that one is not able to feel and respond to another person anymore, which obviously has an impact on patient care. There is also a sense of low personal accomplishment, more than half of them being affected. And amongst the various disciplines, we found that the medical personnel had the highest levels of depersonalization, which obviously affected the way they could deliver care to patients. Allied health had very high levels of emotionally feeling exhausted. And even the non-clinical staff were affected with a sense of low personal accomplishment. So it looks like many of us have really failed the stress test at some time. What are the repercussions? So burnout is not only a personal burden. It affects the individual, as we have mentioned, physical, mental strain, which then leads to behavioral strain with loss of empathy, irritability, having difficult relationships with each other, and some health professionals even turning to substance use and substance abuse. And this has repercussions on patient care. Again, we heard about how vital it is to be able to communicate with patients in order to deliver holistic care. But physician and healthcare burnout can actually affect communication with an increased risk of medical errors and an overall reduction in the quality of care. And obviously, when people are burnt out, they don't work very well together. So even within teams, there may be increased friction, reduction in trust, and eventually reduction in the collaborations. And this has a cost on the systems as well. People being absent often, people leaving jobs, so increased turnover, which also means that the cost for the system becomes really high because we have to be constantly recruiting, retraining, and dealing with lost work hours, and therefore reducing the overall capacity to function and to deliver as healthcare. This is a study that's done in the Danish population to look at how population fares with regards to mental well-being. And we can actually see that it's a normal distribution where most of the population, whilst residing in a state of functioning, there is also a significant level in the state of burnout, and a few percentage in what we call the flourishing state. And if we were to translate this to how individuals would be in how they would be in society, basically in a state of flourishing, people can actually offer more compassion, they feel satisfied in their work, and the way that they would go about their lives would be more flowing, fluid, flexible, and free. And these were all the attributes that, again, earlier this morning were alluded to that was important for collaboration. On the other hand, the burnout individuals would be in a state of fatigue. And if you look at these fight, flight, freeze, it will probably remind you of physiology of stress. And this is what happens to people who are constantly burnt out. Their bodies are in a constant state of physiological activation for stress responses, of fight, flight, and freeze. Now I want to show you in the next slide what I found from our medical students at the Yonge-Lin School of Medicine, and these are fourth-year students. So our medical curriculum is 5 years long, and in the third to the fifth year, they go to the clinics. And I asked them in a workshop we were trying to impart some skills on looking after themselves, where they might place themselves on this curve. And you can see that we have a huge amount of medical students in the fourth year who are already feeling burnt out. Only a few of them feel that they are flourishing. So this is something that we have to address. That why is it, as students are going through their undergraduate or even postgraduate medical training, that they are actually experiencing so much burnout? I will not talk about the reasons now, but we will explore it in the last section of our talk. So, talking so much about flourishing, what is flourishing? It is the wholeness of being and doing, of realizing one's potential, and not just one's potential, but also helping others to realize their own potential. And I would like to quote from the Kern National Network, which is from the US and has come up with a framework for flourishing. And these are some of the factors which we could actually adopt to help people flourish, or could build upon to help people flourish. The first of which is to consider how we might help people build character so that the character traits and the character experiences and characteristics could motivate them and enable them to be agents of their own, whatever they identify themselves to be important for them. The second thing is the aspect of caring, which is practices, dispositions, motivations that aim at not just individuals, but also the whole community to grow and develop and flourish. And individuals who are caring will show that they appreciate that there is interdependence in relationships. We are all dependent on each other for our work, for our health, for our joys. And even within a hierarchical system, we can find trust, we can find humility, and that we all work towards mutual reward and benefit. The third aspect is what is called practical wisdom. Basically, how do we practice with wisdom? And when we wisdom meaning, how do we use our experience to discern what is right within the context of the circumstances that we are facing. And if we look at somebody who is practicing with practical wisdom, that person would know the aims, would seek to act rightly in the service of others, would be able to adapt in complex situations, will be perceptive, responsive, and also can see the grays, which means not everything is just black and white, that there are different grades of looking at things. And also holding other people's perspectives with empathy. Using emotion as an ally of reason for judgment, not as a distortment of our judgment. So what this means is that we become aware of our own emotions. And we do not let that make us reactive, but we use it to actually inform ourselves. How do we respond wisely? And finally, bringing experience into the actions that we do, basically using our experience and being able to discern, again, what is the right thing to do, what is of value to us, and what is of value to others. So flourishing health professionals are professionals then who can be present with patients, who have emotional steadiness under pressure, who can have compassion for colleagues, who can connect within the interprofessional communities and seek collaborations. And importantly, we can all live enriched professional lives, which then leads to really sustainable health ecosystems and growth. So basically, when we look after the individual within our community and help them to flourish, it then actually helps the whole community to flourish. And again, this is so important for the holistic care of patients. So the next part, I'm going to share with you some of the experiences from Singapore. So in 2023, the Ministry of Health in Singapore, together with the Ministry of Social and Family Development, came up with this National Mental Health and Wellbeing Strategy. And they had worked with several other collaborations and stakeholders. And they came up with a statement that really recognizes that the individual's mental health is not just affected by our own psychological well-being, but really is shaped by so many other driving forces which are larger than themselves: biological, social, environmental. And so they set up to have 4 focus areas which Singapore is currently concentrating on and working on: expanding the capacity of mental health services, looking into early identification and intervention, and really importantly for us, promoting mental health and well-being and improving the workplace mental health and well-being. I think these are initiatives that will see many years to see the results, but this is the first step for us to actually create a flourishing health community. I would like to also share with you the initiatives with the Ministry of Health, whereby the challenge, again, facing us is healthcare burnout, which then affects not just the individuals, but has repercussions for patient safety and workforce retention. And in the years 2019 to 2025, there were a series of new health initiatives from targeted small initiatives that now have grown into system-wide transformation. We first started with having focus groups, discussion basically with the postgraduate year 1 students, or rather they are actually students who have graduated and they are now serving the postgraduate year 1, and looking into what they were challenged with and what well-being initiatives could be implemented for them. And then after that, this went on to really also look at staff wellness with the Staff Wellness Committee engaging with stakeholders as well as collaborative efforts, and this occurred throughout the various healthcare systems in Singapore. And we then set up the National Wellness Committee for Junior Doctors, and this is where there were targeted interventions specifically to help junior doctors cope with their work, and also a tripartite work group for the prevention of abuse and harassment of healthcare workers. And now finally, what we have is a well-being framework for healthcare workers, and this is developed by the Ministry of Health together with the cluster chief wellness officers. So in Singapore, our healthcare is divided into or organized into several healthcare clusters, and each cluster has a few hospitals under them. And now every cluster has a chief wellness officer and has a well-being office. So I'll use an example of the National University Health System, where I come from, of the well-being office. And I think what really matters here is that it's the leadership that's committed to staff well-being. And they have a long statement here that tells you that they would like to consider that everyone in their community is really a family, and the members are respected, fairly treated, they feel safe to speak up, and care for each other and take responsibility for each other too. I just show you the team of people who are involved in setting up the National University Health Wellbeing Office. And what they have done really is to come up with a comprehensive suite of resources with health, with employee benefits, well-being, even practical guidance on different stages of life, such as a new graduate entering the workforce, families, young families having children, and careers, mid-career employees going for career advancement, and even for employees who are planning for their retirement. Right, for the next part, now I'm going to talk about what we do in our medical school. And this is where we're gonna have a look at some of the factors which affect well-being, even in medical students and also in residents. So what are the major drivers of burnout and distress in medical training? First of all, there's this thing called problematic mindsets. So what are problematic mindsets? This is what we call toxic or maladaptive perfectionism, which means that whilst we would like to get everything correct, but when something falls out of place, it is just so terrible, we just feel so terrible that it actually stops us from being productive. So this is toxic perfectionism. Secondly, performance as identity, meaning that our professional identity becomes tagged to how we perform. So if for any reason there is any lapse in performance, then we might blame ourselves, and we may actually tell ourselves that we are not a good doctor, we are not a good nurse, we are not a good physiotherapist, how terrible am I? So this is called performance as identity. Imposter syndrome. This is where no matter how much experience we have and how much knowledge we have, we always keep feeling that we're never good enough and we are not that whoever that we have been tasked to be looking after this patient or looking after this colleague. Cognitive distortions. All or nothing thinking. So basically a very dichotomous way of thinking. This is good, this is bad, and if something happens, I'm a success, I'm a failure. These are all not really helpful ways of thinking. There is also the often within ourselves a hyperactive inner critic. So having an inner critic is really helpful because it helps us to reflect on how we can do better. But if this inner critic becomes hyperactive, and then it goes into what we call the automatic negative thoughts, or the autopilot of negative thoughts, and then it would be, yes, I made a mistake. Why did I make a mistake? I must be so terrible. Or maybe I'm so stupid. Why am I so stupid? And you get into that cycle of thought process instead of actually restructuring and saying, what can I learn? Reframing. Right? And that's also not helpful. And of course, systemic factors, stressful academic and clinical environments. So I can tell you that if you ask our students, take a poll among them, when they're seated in a lecture hall like this, what are the stresses that you face in your undergraduate medical curriculum? All of them, almost 80% of them will say it's exams. So I'll introduce you a little bit about our medical curriculum at the Yonglin School of Medicine, where we look into introducing our students to the biopsychosocial model of health and disease, whereby health and disease is determined by a complex play of biological and social and psychological factors, again, very much in line with why we need a holistic approach to healthcare. And we have a 5-year curriculum, but this concept, we start them with this concept from the first 2 years, and then we reinforce this in the clinical years. And besides training them in the diagnosis and the management of disease, we now train them to really consider the patient as a person. So introducing skills like mindful communication, having case discussions about how to alleviate the health and disease of this patient, taking into account that the patient will suffer from psychological and social factors as well, in addition to their health disease burden. But in these recent years, we have also turned towards the students to actually try to empower them and make them understand that they themselves are people. So these are some of the topics that we have introduced: mindful awareness, compassion, cognitive models to understand themselves, how they can navigate transitions, and also towards professional identity formation. And we do this in various teaching modalities like workshops, even mentoring, as well as coaching. So just to run you through some of the topics that we do with our students, to introduce them to the psychology, the physiology, as well as some skills to flourish. The mindful awareness, using mindfulness-based practices. How to shift their perspectives, so stepping out of their automatic negative pilot that I was talking about, how to reframe. How to respond skillfully by knowing themselves and working with their emotions. And finally, some activities that can help them flourish, such as savoring, self-appreciation, feeling gratitude, and how they could also apply this. So for the next set of slides, actually, what I will do is to take you through some of these practices that we actually expose the students to, sometimes maybe in a little experiential way. So let's just talk first about mindfulness. So according to, this is a quote from Professor John Kabat-Zinn, who was really one of the pioneers who brought mindfulness into the Western medicine tradition. Mindfulness is awareness that arises through paying attention on purpose in the present moment, non-judgmentally, in the service of self-understanding and wisdom. So you can see from this quote that there is mindfulness is actually very intentional, and it also comes with a certain attitude of being non-judgmental. And what are some of the effects on the mindfulness on the healthcare system? There is now a lot of literature really to show that it helps the individual develop better personal well-being and growth, with better mood and emotional regulation, better self-awareness and situational awareness, develop self-compassion, including self-care, and resulting then in reduced burnout. The quality of care is also increased when people are more mindful in terms of better cognitive performance, better able to concentrate, with peripheral vision, which means that whilst we are so focused on the task, we can actually widen our vision and also become aware of whatever is going on outside of our narrow focus of vision, which then gives us new perspectives. Recognize and manage errors, openness to new information, and perspectives, and therefore all this really helping us to be centering on the patient for better care. It also improves the quality of connecting with each other and with the patient, all really good for holistic care and collaboration, because people become more curious, more non-judgmental, more empathetic, and with more compassion. So, some examples of our experiential class learning. And this is a phase 1 or year 1 example where I teach the phase 1 students respiratory physiology and pathophysiology. And this is one of our, at the end of it, of all the understanding about how breathing is driven, what are the mechanisms that can affect breathing. We take them through this activity where they get to anchor themselves, the anchors being the feet, the seat, the hands, and then take some deep breaths. And what this does is really connect them with their understanding of how this turns on their parasympathetic nervous system, which is always in contrast with the sympathetic nervous system. And many of us, especially healthcare professionals, and many people who work with very high-paced jobs, our sympathetic activity is basically at a default on state. And it's really difficult for our parasympathetic to actually gain a balance. But a simple activity like this, grounding, giving you a sense of stability, and then deep breathing actually turns on the parasympathetic system and actually helps people then to calm down and to better able to focus on what they really need to do. And then in 4th year, we have a professional practice workshop for future doctors. And here we again highlight how the mind and the body are interconnected. So we often think of our stress response as being a result of external triggers, physical triggers, social triggers, environmental triggers. But we are not often aware that our stress responses can also come from within ourselves when we perpetuate a lot of negative thoughts, for instance, or we process a lot of negative emotions, or we feel physical pain. These are additional triggers that can cause stress. Again, I want to share with you something that I found with my class. So they were asked to reflect on this scenario. The tutor asked a question, how to explain between the clinical presentations between 2 different medical conditions. So you as a student face difficulties answering the question. You give an answer which the tutor replies, your answer is wrong. This doesn't answer the question. What immediately comes to your mind and how do you feel? And I tell you that almost 80% of the class came up with this answer. They feel shame, which to me is really revealing and a little bit much of, gives me some food for thought, because I reflected on this and asked myself, if within such a condition they already feel so strongly and shameful, what repercussions would this have in terms of, for instance, patient care? It would mean that perhaps they may not dare to ask questions in areas that they are not sure about because they feel ashamed to be exposed of their inadequacies. Now, this would lead to quite serious repercussions for patient care, for instance. So we also introduced them what is called the cognitive model of reactions and actions, which is very much used in the psychological counseling nowadays. Why is it important to be aware of our inner environment? And it is because this model really explains that every day that we go about, our thoughts, behavior, our body sensations, our feelings, they are all very interconnected. So let me give you some examples. For instance, if today we are feeling tired, then we may just feel moody. Then the thought that comes to mind is, I wish I didn't have to go to work today, or didn't have to go study today. And then if we do have to go in, maybe we get irritated with our colleagues, with our patients, with our friends. But imagine if you woke up and it's like, happy day. Immediately the thought that comes is, I'm really looking forward to meeting other people. And then somehow this speaks to your body. Immediately your body starts to perk up, you feel energetic. And of course your behavior, you will be actively engaging with people, with what you need to do. So why this model is important is that if we can actually be mindful of our thoughts, our behavior, our body sensations and feelings, we then actually can have the knowledge of our internal environment. This is all our internal environment. We can have the knowledge of our internal environment, how to respond. So in order to be aware of these thoughts, these feelings, body sensations, and our eventual behavior, we give this exercise to our students. It's called the breathing space. It's taken from the University of Oxford Mindfulness Center. And I actually invite all of you to experience this for a few minutes. So perhaps taking a comfortable position. You might want to sit upright so they can breathe well, and the feet on the floor if you like. And just the first few moments, if you like to, you can close your eyes or lower your gaze. Just the first few moments, just scan your brain for whatever thoughts are coming in, whatever that is there. Almost like a curious scientist asking, what's in my brain right now? What thoughts are coming in? Without any judgment. And then also turning towards whether there might be any emotions coming up right now. Again, bring that sense of curiosity. And perhaps what physical sensations may be coming for you too. Is this room feeling colder, warmer? The touch of the clothes on your body. And then the second step is a step of anchoring. So we may choose to anchor ourselves on the breath, breathing in and out, just focusing on the breath. You may also choose an anchor, like the anchor or the touch of your hands, if you like to put your hands together. Just feeling that sense of steadiness and ourselves being present here. And the third step, now expanding that sense of touch, or that breathing, and imagining that now you're breathing through the whole body. The whole body is breathing. And there is a space in which your body sits, and your breath is moving into that space around you. And with that, we can ask the next question. What would I like to do in the next moment as I come back to this room and open my eyes? So this is one of the exercises that we actually basically can be done in even 1 minute if you shorten it, or 3 minutes or even longer. And it basically allows us to actually come to be present and also to be away from, the automatic process that's going on in our heads, and to be more self-aware. Okay. I have 5 minutes, so I will have to rush a little bit now. But just to let us know that quite often our minds are really very much focused on the negative aspects of our life. What went bad sticks in our brain much more than what went good. So basically, we have to intentionally focus on our positive experience and make that intentional. And so we do this with our students too. It's an appreciation exercise where we take them through a few fingers. They can think about what they appreciate during the whole day, perhaps something they appreciate about themselves, their colleagues, their families, even simple things like, I appreciate the fact that I've got this laptop to work on. And also the concept of mindful compassion for self and others, which is taken from Christine Neff's work, where mindfulness, being aware of the physical, mental, and environmental pain of the moment, but also the attitude of being with them as they are, not wishing them to be this way or that, is a very critical component of bringing mindful compassion for self and others. Common humanity, recognizing that we are not alone in our struggles and that we are interconnected actually through our struggles as human beings. And treating ourselves with kindness as we would treat others with kindness. And we also do activities with them like mindful body movement with self-care. The post-survey workshop survey showed that the students appreciated the techniques, but I think what was really important was that they actually brought about talking about how common it is for medical professionals, especially PGY ones, to feel burnt out was really so important for them. And they would also appreciate actually bringing forward many of the practices into their daily lives. So this last part, really, I just want to show you some of the programs that we run in the university, in the medical school. We do have workshops now where we focus on training our faculty, our staff, participants coming from various disciplines in healthcare, as well as educators and even young researchers and administrative staff. We have also implemented a Master of Science in Human Potential and Performance to help the master students actually learn how to apply physiological, psychological, as well as neuroscientific principles for human potential and performance. We have set up platforms, digital IT platforms, where people can learn for themselves, and these are all online. And finally, we have collaborations with the Rochester School of Medical School, where we bring these mindful practice, now called Flourishing in Medicine workshops, to help professionals and anyone who is actually linked in some way to healthcare. And these workshops actually explore these very important topics, which in an immersive experience with focus skills training, noticing with awareness, managing conflict, flourishing, how to respond to errors, working with suffering, grief and loss, and even also looking into organizational change. So I'd just like to leave you with this quote from John Kabat-Zinn again. Maybe we can't stop the waves, but we can learn to surf, and we can teach our students and our faculty how to surf. And also, why not? Even if the winds come, 迎风接浪, harness them, flow with them. And finally, really important, 同理他人, 上至正宗, whilst we are looking after others, how about looking after ourselves as well? And with that, let me invite you once again to visit me in Singapore. Thank you.
Thank you for Professor Ye's excellent speech. So she tells us that Singapore has established several systems to support the healthcare work well-being. So I think our audience must have several questions to want to ask Dr. Ye. So any question from our audience? Dr. Lee.
Thank you, Professor Yep, for your wonderful and inspiring talk. It really reasons to me because as a physician in the hospital and also as an educator to our younger trainees, we do face a lot of stressed out students. In our hospital currently, we send electric questionnaires for self-reporting of the students' stress, like the emotion thermometers, every month to our UGY and PGYs. But to our experience, we really think that the questionnaire they reported is not really reflecting their true stress, because most of our students will report, oh, I'm fine, extremely fine, 0 points most of the time. But still, we often and really frequently facing that the trainees suddenly collapse during their training or working in their clinical practices. So I wonder, are there any really truly effective or survey or monitoring process in Singapore that can really show that how much the stress and the students is really facing? Thank you.
For your question, this is really important, but also a very difficult question, because we also face very similar issues that when we actually administer questionnaires, people are quite often under kind of reporting what they are truly facing. One of the things that I think our students are often worried about is how anonymous these their replies would be. We face it in our school as well. And in fact, I think some of the best ways that I have tried recently is to use a platform like a real-life platform where they can actually reply anonymously, and then we really have a scatter plot of where the students are. And when they're then you're asking them, what do you face as stresses? You will find that they're typing in a lot of stuff. And that's because I guess it also means that they feel safe in that environment where it is not, they don't feel that it's something that will be collated and perhaps tagged to their academic performance. In a sense, I think for a long time, this was also the case when there were questionnaires that were administered to staff, and it wasn't really truthful. So there was a lot of efforts actually made from the leadership level to reassure the staff that this would all be anonymous and it wouldn't be, that nobody would know who had actually keyed in the responses. So I think these are really important. So even if you had a very well-designed questionnaire, I think these are some of the personal considerations that we need to take into account. Would that answer your question? Thank you.
Because time is limited, so we must close this section. Okay. So thanks again, Professor Ye. So
Thank you.
On behalf of our hospital.
Thank you for all the insightful questions. To express our sincere appreciation, we would like to invite Professor Wang to present a certificate of appreciation to Professor Ye. Please look at the camera and smile. Thank you, Professor Wang and Professor Ye. Please return to your seat. Now, it is my great honor to invite the moderator of our next session, Professor Lin Jingsheng, Deputy Director for Teaching of Tri-Service General Hospital, to introduce our second speaker. Please join me in welcoming Professor Lin.
Good morning, ladies and gentlemen. And it's my great pleasure to introduce our speaker, Professor Liu. Professor Liu is a very energetic and active, engaging doctor. He is a rheumatologist and also a physician educator in our hospital. He teaches students very actively. One of his very famous thing is that he led the more than 40 students to write a paper and submit to the SCI journal. And so he always taught a student as his son, his kid. And previously, he also did the program of interprofessional communication in our hospital. So today, he will give us the talk regarding how to apply AI in how to apply AI to interpersonal communication and how to evaluate the performance. Let's welcome Professor Liu.
Thanks, Professor Lin's kind introduction. Professor is my role model in patient care, medical education, and academic research. This is my great honor and for me and in here. Also, dear professor and the teacher and the colleague, my function Liu, my talk is AI-derived holistic and interprofessional care, and from scalable medical education, the model, and from our Transmitted General Hospital to global practice. Sorry. Okay, as Professor Lin, I'm a pneumatologist. So besides our take care lupus patient, I think maybe I can do something for medical education. So this is Amy and poster from 2015 from Glasgow. This is my healthcare matrix and stimulation. And then finally, virtual patient and final and healthcare the medical education and interprofessional IPP and IPE. Okay, and so traditional is submission assessment and the frequent knowledge. So, and the feedback. So we want to change. So in AI and 1 minute, I create a 1 minute summary. So I'm competence based. So we objective and standard and holistic and real time and accessible insights. So we create a 1 minute summary to show everyone. So is our training model in our hospital. So traditional is the class. So we want to the high speed with a virtual patient and from Bertie and Innova is from high facility. And then we will prepare and almost done and for high quality of patient care. And so we will immerse of training from incubate structural clinical rhythm and identical potential physician sciences. So we create a 1 minute summary. It's like a QR code. Just 1 minute summary from every student, and they can immerse, can enjoy, can experience our 1 minute summary. And so is only 6 seconds concept real. So just very simple lucky 7 from complaint history, physical and lab and diagnosis. And whole is very horizontal care. It's thanks to created by Dr. Zheng Wenrong. So when the finish the 1 minute summary have 2 domains, is a knowledge domain and a horizontal domain. So very quickly, maybe 1 minute, he will get the 2 scope. And so it's very to new QR code. First, you can log in. And you can just your case and the first attempt and AI will feedback. So you can review feedback and the second attempt. So we was like the feedback cycle, and so pre-test and post-test. So you can follow the feedback concept. You can get better. So just from maybe Clark, maybe 1 degree medical student. So it was just depends like 1 minute summary system. So this real case, Long Xiaojie is my patient. So we 1 minute summary, just like lucky 7. And then we have special is 5 home and 4 acceptor and 3 element. So 五权三要素四面是 our whole healthcare evaluation score. So we found my patient 4 times tried for 82 and the 295 score, and the horizontal scale make it 88. So so our student can immerse like a 1-minute summary system, and they can get a real time to get back, and so you can choose with a high score. So this is the patient waterfall. So I suggest my clerk and student, you will do the research because you will become the physician scientist. So this is our case. So Long Xiaojie, and he was a lupus patient, but he has a stroke. So then we were biomarker, and then our horizontal care. So here's the summit and 2024. But 3 weeks later, the paper published. First author is Clark, and so he can eat independently. So we was just patient care and submit paper and to show our research. So maybe the PowerPoint delay. And so this first author, so he is produced the national scale, national and the God's one, and he have this was the poster. So the Dr. Chen Jingyuan. 2 days later, he was a PGY student, but 2 years he was a clerk. He produced because he was writing scientific research. So in the clinical practice, he can got the prize and to champion. And then we will move to this case of the holistic care and healthy care. It's under 2033, and so is our president, and he will got holistic prize from stimulation and the round table run, and so this is our sample. So this is our holistic care. Move to the next Barcelona Amy poster. So this from medical knowledge and holistic care. This is Clark, our PGY student Xie Tingyu. Also have like the PD-1 Treg. This is our marker, and to purchase the Nobel Prize and before and after. And then we were 2 years ago in Brussels, also in Dr. Xie Tingyu, our clerk, but he became PGY. He was from virtual patient, but with real patient for paper submission, and then to the medical student and the medical practice in virtual patient. So was also in Treg biomarker, but the paper so. Not only the paper published, but also medical student in Amy poster presentation. Is from our expert on our Xie Tingyu. So we will listen, look immediately and the medical AI feedback. So maybe you Clark and the medical student, he made medical experience, but he can try and error. So we will but we will our students have the sympathy and the compassion. So we want to the 5 whole, 4 aspects, and the 3 elements. So we will, as AI feedback, how to get better. And so we will keep in the sympathy and to the compassion. So we will reward our monthly, we have the interpretation conference. So like October cardiology and December. So we also enjoy our clerk student and the pre-test and post-test. So our clerk is improve and to the 67 and to the 82. And also have the national board exam, but include very high scores. So. And then so we will cardiology and urology, so we will kind of improvement, and then so we will like index alternately, and then we have our professor, superintendent, and the teacher, so together, so we can see the holistic improvement and the certification, and he will both score will increase. This is the next October, our from 1-minute summary, and to holistic care, and to not only the medical domain. And then we will have the 3D and assessment framework. So we was Amy, knowledge and to holistic C and Air Force and to 6 domain. So we will create to the detailed framework and compare with Tri-Pacific General Hospital. And so we are Air Force, Army, and the Navy. So just 1 minute summary, some feedbacks and to the from its efficiency to get a high score. And so we will set up from the ACGME and like to the holistic care. So this is Amy for we 1 minute summary, and can we have the 25 submit paper, but I'm the 10 steps poster, and then have short convention 4 and e-post 6. And so from I have very lucky have the AI summary and the skeletal framework as to enhance and the clinical reason and the holistic care in medical education. And oh yeah, that's and so they have the and that to the trace the Zhang Sanyue a virtual patient, and Jiang Zhongda was also the cardiology and the 2 urology. So was also in 1 minute summary, and we have the Chinese medicine and the 2 dentists and the nursing was also your like interprofessional conference. I used the 1 minute summary and can to present in next week in AMI. Oh yes, that's dentistry and the Chinese medicine was also joins our monthly and the interprofessional distance conference. Oh yeah, so this is my post is skeletal framework 1 minute summary, clinical reason, and holistic. And then we have, but this submit data is this February, so only 1,300 attempt to 1 minute summary experience. And then we have them to, but the temp is through the 2,500. Oh yeah, so this our e-poster, but with on demand. So we will share our 1 minute summary in the clinical reason and holistic care in medical education. Okay. So this week I have up to the 2,518 times so attempt, but Okay. How? But and so next week, and we can up to and so the very score have attempted to the 900, but we have quite a nice score. So we have also the knowledge domain, horticultural domain, and Air Force the 6th domain, and so we have. Sorry. This is Zhang Sanyue. Is a virtual patient from the 1 minute summary and the 2 summary. And really Xiao Boren was also in her. Oh, okay. Sorry. Xiao Boren was also in urological and through cardiology. Just choose the 2 times and to have the 1 minute summary. This is Jiang Zhongda was also in urological and to from background and the challenge just like to this 1 minute summary and to get to how our clerk and to get a better Jiang Zhongda. It was also on demand and to show this our experience in our next week AMI in Verona. Okay. Thank you. So we are before and after from class. Okay. And then with very special is World Congress Internal Medicine 世界内科医学会 and it's November. And from first also is our PGY student. He was purchased our internal medicine have the mortality conference and the clinical pathology conference in the resident doctor. So from Clark and PGY and our medical student. So this is our interdepartment Liu Xilin was also in the 世界内科医学会 in this November in Nangang. And it was also brings to the 1 minute summary. And but we was choose is PGY2 student. He was very special in focus in clinical logical score and holocaust integrate score. But very lucky from Amy Poster and to WCIM in this November. So we were incubated. So I encourage our medical student to produce the poster and the paper project. So, and thanks Professor, so far maybe next 4 years, have the 14 paper SF published. But we will identify the high potential student because he will grow, because he will produce his PGY training hospital. He must be well prepared, have the poster or paper, but you can well train in a hospital in PGY. So we will identify with undergraduate, maybe early in freshman or medical student. So we were to, 6 years ago, I found a postdoc to Tokyo University. And this is 2018, I'm in Fukuoka, and see the Nobel Prize is immune checkpoint in immune oncology. So maybe cancer treatment may be from horticulture, maybe hospice, maybe aggressive from treat to cure. So we will identify the PD-1, and then we'll move through the Sakaguchi sensei and take a picture together. We want to immune tolerance from PD-1 and Treg. So we will identify the marker is PD-1 and Treg. So the 40 paper published, the biomarker is PD-1 and Treg. Okay, then we want to just to the high level with Nobel Prize biomarker. So we will set up the form and the Gemini and the Grok K and the True Cloud GPT. And the first, and we will quickly summarize and follow the textbook. And then we also check the Gemini and the Magdalene, and then we will note and to educate. So we will the framework through the case and a very, maybe 1 week or so. But from this framework, maybe 2 hours, and can very quickly, and then our student and the capacity. So this, so we will from this and virtual patient and real patient, and we'll attempt to take a video, and so we'll produce. So far is and for the clinical student, and so you will from 2023 and to this year maybe have the 40, and then we will have to move to when the basic medical domain, he can pass the high level, and we'll move to he will vision science and up to the holistic care and the patient care quality. So, okay. Maybe have some like. Maybe so, okay. Okay, so. And then, so you are 40 people on the, we will produce the vision science system. And so very special is first degree and the freshman. Yeah, you have the my paper, so is Wu Changlong. And so we will the pre-treat and the post have the marker, the PD-1. And so we will so far have autoimmune infection and neurological and others. So we will most popular in vivo and other paper publication. And just see you see and see and how to create from case flow and from and move through the original article. And even he was a medical student, but you can early exposure clinical practice, early in clinical medical research. I produce our student and can move to. So it's like a Barcelona or Barcelona, the paper case paper published was found here. Sorry, this found here. This is immune phenotyping in the heat map. like a lupus patient. But we will marker is compared with health control. This is a PD-1 and the T-reg and the B-reg. So we will produce like maybe have the 10 case report and produce and to writing from basic. And then we'll move to and the high level. So, and this have the paper published on PD-1 and the 2018 hormone the Nobel Prize PD-1 immune checkpoint and then the immune tolerance the Sakaguchi the T-reg and only in lupus. But most of the traditional is in cancer patient. But we moved to the lupus. So it was international with Anna. Anna is an electional member with Ukraine. Ukraine is Clark. She moved to the one Taipei state. And so we were between Taiwanese and Ukrainians were different. He was maybe the low PD-1 and a member, high member. So he was our and the course and then he was our this paper course. Then you will enjoy our 1 minute summary. From is a medical student and she joins 1 minute summary and he want to show you a video, your experience, and back to the Ukraine. And say this, and so we were very lucky in the Taiwan and the Taiwan National University Hospital, and can have the award, the post award. And then when he back, he will produce the physician science, so he will get a PhD. I'm really happy to have the two recognition. So he found 1 minute summary and can have the And so I have thank you. I have 5 minutes left. So we'll move to freshman. Next year, he was junior high school student. But he will just try error. 1 minute summary, he was at 70, but he was not insufficiency of knowledge next year. But only just make, just fine. So you can try an error. You will know how to go. This is our freshman. 6 months later, 3 papers published first author from the PD-1 and from the immunophenotyping and the IVIG helpers. So he was a freshman. And then we'll move to this Wu Changlong. He will present next week in Vienna. So he will present in the metaverse and with the publication. 医疗无国界 大一新生会说 he was in this next Tuesday afternoon at 2 p.m. in the 8X classroom. So we will enjoy the 大一吴长龙 he was planning. So finally, I will thank Professor Hong. He helped us from noise and to master is our BMC, the medical education. He published the Heidegger paper called the virtual patient and integrate the dermatology and the precision education. I know the student is efficiency, but from our 1 minute summary and can upgrade and to the master. So dream bigger and do bigger. So the 起承转合 is 1 minute summary and the AI drives the physician science is our chair. So this very so touch move in the 6 years ago. Take a picture in Taiwan 9 and the beautiful river the Ivana. And the next week I will move to the Verona and the brief through the and the 10 poster and AI Frank to the 1 minute summary to share our experience in Verona. So this well and so it was deep cooperation and with HTC Virtual and Innova and NVIDIA and from AI's 1 minute summary. And so this final will take home message, and so we are AI powerful patient care, interprofessional, and through the outcome drive the impact. And finally, we have the patient-centered university goals. This, thank you. This is my presentation. Thank you.
Thank you, Professor Liu's excellent talk. I think Professor Liu just provide a chance to let us know how our physicians have so engaged in teaching for their young faculties. And also use AI for assessment. But for the time issue, I think this section should be closed here. And thank you everyone for your participation. Thank you.
Thank you, Professor.
It's my pleasure to invite our moderator, Professor Lin, to present a certificate of appreciation to Professor Liu. Professor Lin and Professor Liu, please come forward and face the camera. Thank you, Professor Lin and Professor Liu. Please to your seat. We would like to thank all the speakers for their excellent presentation and valuable contribution. This concludes these sessions. Ladies and gentlemen, please note that the afternoon session will begin at 1:30 p.m. We kindly ask everyone to return to the conference hall and be seated by 1:25 p.m. We will now take a break for lunch. During the lunch, we invite you to visit the poster exhibition and interact with the presenters. Thank you for your participation this morning. Enjoy your lunch, and we look forward to seeing you again this afternoon. 各位长官及贵宾好，下午场次将于1点30分开始，敬请于1点25分前返回会场。接下来进入午餐休息时间。欢迎各位贵宾参观会场外海报展示，感谢各位上午的参与，祝大家用餐愉快，我们下午再见。 声音测试。 Good afternoon, ladies and gentlemen. Welcome back to the International Symposium on Holistic Care and Healthcare Quality 2026. The afternoon session will begin shortly. We kindly ask everyone to return to their seat and ensure that your mobile phones are turned off or switched to silent mode. Thank you for your cooperation. 各位长官及贵宾午安，欢迎各位回到2026全人照护与医疗品质国际研讨会。下午场次即将开始，敬请各位贵宾返回会场并入席，同时将手机关闭或调整为静音模式，以维持会议顺利进行。感谢各位贵宾的配合。Good afternoon, ladies and gentlemen. Welcome back to the International Symposium on Holistic Care and Healthcare Quality 2026. It is now our pleasure to invite Professor Cai Jiansong of National Defense Medical University to share a few words with us. Please join me in welcoming Professor Cai.
Thank you so much, distinguished guests, esteemed colleague, and our good friend. Good afternoon. Actually, I'm very happy to, on behalf of the Taiwan Healthcare Quality Association, Council of Patient Safety, to say some more for this conference. I have had the honor of accompanying the Military Medical Bureau growth, witness firsthand our transformation from mission-focused operation to a forward-looking, world-class medical benchmark. On this milestone, 80th anniversary of Tri-Service General Hospital, seeing how TSGH served not only as a rock of health for our armed force and the nation, but also as a leader in advancing healthcare quality and patient safety, fill me with pride. I have always believed that quality and safety are the most important lifeline of the medical care. The four key talks organized for this afternoon symposium comprehensively map out the future of the healthcare quality, range from international perspectives and the national policy to health system reflection and clinical innovation. It's my honor to introduce this talk to you. For our first talk, we are privileged to invite Professor Shin Ishiro from the Kyushu University Hospital, Japan. He will present healthcare quality and safety in healthy aging society, domestic and global perspectives. And the second talk is the promoting holistic and sustainable healthcare, presented by Professor Zheng Zhongfang. He is the Chief Executive Officer of JCT. The third talk is the current state and the challenge of quality management, presented by Professor Ba-Chun Wang. He is the Vice Superintendent of Keshe General Hospital. And the final talk, we invite Professor Zhichong Hong, the Director of Department of Dermatology at the Tri-Sub General Hospital. He will present flipping the clinical, shared decision-making as a pathway to national healthcare quality recognition. I hope all of you enjoy this section and the symposium a complete success. Thank you very much. Thank you.
Thank you, Professor Tsai, for your valuable remarks. Please return to your seat. Next, we will have a group photo. May we kindly ask those seated in the middle remain seated, and invite those seated on both sides move toward the center so everyone can be included in the picture. 请坐在两侧的贵宾往中间走道移动，我们将拍摄一张大合照。坐，谢谢。Before we begin, the organizing committee would like to make a brief announcement regarding timekeeping. To help keep today's program on schedule, we will remind you when you have 5 minutes and 1 minute remaining in your presentation, and remind you again when your time is up. Thank you for your understanding and cooperation. Now, it is my pleasure to invite the moderator of our first session, Professor Tsai Jian-song, to introduce our first speaker. Professor Tsai, the floor is yours.
Thank you. The first speaker will be Professor Shin Yushiro. Before his talk, I briefly introduce Professor Yushiro. Professor Yushiro is not only an outstanding clinical expert, but also a globally recognized leader in healthcare quality and patient safety. Based at the prestigious Kyushu University Hospital in Japan, he has long been at the forefront of the hospital quality management and the healthcare system redesign. Beyond his institutional accomplishment, Professor Yushiro played a pivotal role in Japan's national accreditation system through the Japan Council for Quality Care. On the global stage, he served in vital leadership role within both the ISQA and the ESQA, driving the international standard and the policy improvement. Today, Professor Yushiro will share his valuable insight on healthcare quality and safety in healthy aging society, domestic and global perspectives. Let's welcome Professor Yushiro.
Thank you very much. Thank you. Thank you very much, Professor Tsai. And honorable leadership members of the National Defense Medical University and the Tri-Services General Hospital, and organizing committee and the teams and the distinguished guests and participants. Very good afternoon to you. And my name is Shin Shiro. I'm from Kyushu University Medical Center, as shown here. And I also work, the Kyushu University is based in Fukuoka, Fugan-shi. And I also work in Tokyo, Donjin. I work for JQ that provides hospital accreditation service and other services. I'm going to touch on other initiatives later on in my slide. And at the international level, I work in ISQA as a board member, so I'm going to describe a little bit about the ISQA activity in my talk. But before getting into my talk, here you see the Kyushu University Medical Center. And maybe 2 weeks ago, you came across a big news from my country, which is a big earthquake which happened in Kumamoto, Shomben. And Kumamoto is close from Fukuoka. It takes only half an hour by bullet train. So since the earthquake happened, Kyushu University has been providing assistance to Kumamoto University and Kumamoto hospitals in such a way of providing medical service, dental service, and psychological service, and etc., etc. And soon after the earthquake happened, your president, President Lai, your Vice President Xiao, and your Premier of Taiwan, Premier of Taiwan Zhou, kindly donated their personal money for disaster relief to my country. So I really appreciate your kindness on this occasion. So all the phrase, but meaning phrase, a friend in need is a friend indeed, resonates in our mind across my country. So thank you very much. Thank you all. So I meet many Taiwan friends this summer, July, August, September. I call my schedule Taiwan Summer. I welcomed a delegation from Chanfa Christian Hospital, and I met them at Kyushu University Medical Center. And 2 weeks ago, Joint Commission Taiwan, delegation of Joint Commission Taiwan, Ministry of Health, and other experts visited the JQ office in Tokyo. Unfortunately, I was unable to join in person because of the earthquake, but we talked virtually each other. Thank you for coming. And today, I am meeting you. This is the third event. And fortunately, next week, I will come back to Taipei again for Tsuchi Hospital Taipei International Conference. And my Taiwan summer will be completed in a big event, Taiwan Night, held by Taiwan Healthcare Quality Association, led by Professor Tsai in Dublin, Ireland this year. I'm looking forward to it very much. Okay, I'd like to go into my talk. So, 现在开始吧. Thank you very much. Thank you. Thank you. And this is a demographic change that has been happening in my country. Please note that total population of Japan is shrinking rapidly, and you see the growing portion of elderly people at the age of 65 and older is growing. Now it is at 29.4%. It's been said by research that the portion will increase up to 37 or 38% by 2070s. Well, this is a big issue in my country. But after the World War II, during a couple of decades, my country was young, so we focused on acute care. But in early or late 1990s, we got aware of this issue, growing aging society. So we launched the national public insurance for nursing care in 2000. But we are now facing not only aging issue, but also aging of aged people, particularly the population of people aged 85 and older is rapidly growing in my country. This is the latest issue. And in the initial couple of decades after the World War II, we focused on acute care, and we developed resources, including human resources, and we built hospital and clinic rapidly. And then we launched National Medical Insurance Scheme in 1961. It's working very well in my country. The co-payment is only 10% basically, so it's affordable. And then here you see the medical fee medical fee list, price list. We developed the price list, and now it became very detailed and complex to cope with the wide variety of medical care, including robotic surgery and very expensive drug for such as muscular dystrophy, which costs $1.5 million US for one vial, for one round of treatment. $1.5 million US is very expensive, but it's covered by our national insurance. And at this point, I'd like to talk briefly about UHC, Universal Health Coverage. Universal Health Coverage is promoted by WHO and the United Nations as well. The definition is that all people have access to the full range of quality healthcare service without financial hardship. So it must be affordable. It must be cheap enough. And it covers the full continuum of essential health services. So people say that my country achieved the UHC at very early stage because of the National Public Healthcare Insurance Scheme. So here you see the very renowned and famous WHO three-dimensional diagram to describe universal health coverage. And here you see vertical axis, we cover all the population, all the people in my country. And here you see the coverage of services, we cover all the services, including robotic surgery. And financial protection, the co-payment is very cheap, so it's really affordable. But the building the delivery system, building the insurance scheme is one thing. It is very important, but quality is another. So we also need to focus on quality. So come to think of quality, JQ has been conducting hospital accreditation like Taiwan Joint Commission in your country. And we have now covered 2,200 hospitals among 8,000 hospitals in my country. So the coverage is 27.2%. But at the same time, we mainly accredited large hospitals. So the coverage of number of beds in my country is 42 or 43%. So I'd like to, this is also a slide related to hospital accreditation. When the government launched national policy on patient safety, the hospital accreditation is clearly included in one of the pillars to promote patient safety. So our government included many price items closely linked to the hospital accreditation. Some were mandatory, but some were recommended. But our people, our nation is very funny, so we do not know how different this mandatory and recommended. So even if the item is recommended, we think, oh, it's mandatory. If it is mandatory, we think, oh, it's mandatory. So the hospital accreditation is strongly promoted by our insurance scheme. We are keen to international norm, international standard. So JQ is a member of ISQA, International Society for Quality Healthcare, as shown here. And we were closely working together with Taiwan Joint Commission, which is also a member. So at this point, I'd like to talk about a little bit the initiatives run by ISQA. Here you see the lineup of ISQA initiatives. I'd like to focus on number one, which is International Accreditation Program. Okay, ISQA has been providing unique experience of external evaluation to national accreditation body like JQ and the Taiwan Joint Commission. And the initiative was launched in 1999. Yeah, 1999. Now and currently, it is being carried out in 35 countries, providing accreditation to standard and organizations and the surveyor training program, and last but not the least, the patient safety training programs. And ISCA publishes the guideline and the principles for standards. And we revised, ISCA revised last year to have the latest one, 6th version, 6th edition of the guideline, including new items which ISCA requires accreditation body in the world to embed in their standard or in their standards. Those are sustainable care and the digital care and the artificial intelligence AI and supporting the care workforce, including mental wellness. And if you go into if you get into details of this document, you will see the artificial intelligence at the pillar 7. Of course, ISCA requires accreditation body and standard to promote AI embedded in their healthcare systems. However, ISCA also requires a standard to support those who do not have an access to digital technology like AI. So we request global accreditation bodies to support that populations. So it is related to the quality and safety in aging society. So another thing, I'd like to touch on reporting and the learning system very briefly. In JQ, I'm working not only for hospital accreditation, but also for reporting and learning system. The first one, with the scope of hospital and clinic, was launched in 2004. Ever since I have been in charge of these reporting and learning system with JQ symbol. And so we have many reporting and learning system with the scope of not only hospital and clinic, but also community pharmacy, dental clinic, and investigation system for birth injury and birth injury. Last one is a reporting and learning system for long-term care facilities, nursing care facilities. I'd like to talk about this later on in my slide. So here you see the overview outline of National Adverse Event Reporting and Learning System. We collect incidents from medical institutions through web-based reporting system, and we produce annual and quarterly report, monthly alert database, and we provide opportunity for training such as root cause analysis. And monthly alert is issued on monthly basis, literally. So we have published 230-something monthly alert so far. It's really popular in my country. So I have talked about quality and safety in healthcare, particularly acute care and a little bit chronic care so far. And here, with this slide and onward, I'd like to talk about long-term care or nursing care in aging society and quality and safety. Back in late 1990s, the Ministry of Health issued a white paper highlighting long-lying elderly. Looking back at my career 30 years ago, I saw patients who were hospitalized for more than 3,000 days in small hospitals. So I visit those hospitals and I saw those patients, and when clinical round, I say, "Oh, Mr. XYZ, today is the 3,300 something days of your hospital. How are you?" This is the conversation. So it's very weird. So those patients were almost living in the hospital. So the Ministry of Health highlighted in late 1960s. And in early 1970s, the famous novelist Sawako Ariyoshi published a novel highlighting the issue of senile dementia, particularly heavy burden on family members who take care of family members with senile dementia. And this issue was really highlighted in our society. And in late 1990s, Fumio Yamazaki, who is a physician, published an essay saying that dying in a hospital, what does it mean to our life? Because in recent generations, significant number of people do not want to die in hospital. They want to die at home or in places that they like to stay and spend the last minute. So, coming back to nursing care, we similarly have developed resources, including human resources like this, and we developed a nursing care insurance scheme like this. The co-payment is basically 10%, and if you are wealthy people, you pay 30%. And then there is a rating system depending on the degree of frailty. From 1 to 5, and support level means that you do not have to receive nursing care, but you may need to nursing care in the near future. So you need rehabilitation. So the question is, who rates the degree of frailty? Of course, physician is involved, but the key person is care manager in care planning office. Care manager, most of them are nurses, and they help physicians in rating precisely the degree of frailty. The degree of frailty depends, the benefit from nursing care insurance scheme depends on the frailty. So let's enjoy this slide. We call care manager because Japanese people loves to shorten the words because it sounds very cute. Do you know the word kawaii? Kawaii. Yeah, it sounds care mane sounds kawaii. Care manager, boo, kawaii. We call pocket monster Pokemon because it sounds kawaii. Pocket monster is a monster, boo, kawaii. So care mane is a very, very key person in nursing care delivery system. And here you see the price list of nursing care insurance. Very detailed, very complex. And please note that medical care insurance fee is revised every 2 years, and the nursing care fee is revised every 3 years. So they are concurrently revised in every 6 years. So it happened in 2024. So here you see the budget, the amount of budget of medical care, medical fee, and the nursing care fee. Of course, the medical fee accounts for majority of the budget. However, the growth is faster for nursing care. And I'm sorry, this is a very detailed slide, but this is the wide range of nursing care services we have developed since we launched the nursing care insurance scheme. We provide visit care, of course, and we provide daily day care in which we invite elderly people to our place for rehabilitation, playing game, or athletic, etc., etc. And we also provide facility-based care. The elderly people with severe frailty lives in the facility. And we also provide preventive care. And in addition, we provide very tailored care which is managed by municipality government. For instance, this service is covered by nursing care insurance budget.
which is scheduled patrol, on-demand visit nursing care. This is a service in which our nursing worker visits your home, and then it's 4 p.m. I came here to see you are doing well. You are well, okay, I will come back, and this visit is recorded and shared with stakeholders in community. But if the nursing care worker receives a telephone call from the user for on-demand response, we respond to the user in that manner. And if the care worker received immediate visit call, those people visit immediately. This is one of the very tailored service covered by nursing care insurance scheme. So the slide was really detailed. And once again, building the delivery system and the nursing care insurance scheme is one thing, but quality is another. So at this point, I wonder, what is the quality in aged society, care in aged society or nursing care? So one of the answers, my message is that the integration of different care settings is essential for high quality care and safer care. Here you see two data. First, you look at on your right side. Here you see the rapidly growing population at the age of 85 and older. So this is this aging of the aged people that we face in my country. And if you are at the age 85, nearly half of the people receives nursing care as well as medical care. So those people receives all kinds of care, medical care, nursing care, and if they are not wealthy, they receive welfare care, etc., etc. So we need to integrate those different cares, those different services for high quality care and safer care. That's the conclusion at the national level in my country. And they may stay at home, they may stay in hospital, they may stay in long-term care facilities. So we need to collaborate. Those facilities need to collaborate each other. But saying that is one thing, but implementing those integrations is another. It's not easy in my country because acute care, long-term care, welfare care have been developed independently. So the peoples are different, the operators or the owners are different, cultures are different. So it's quite difficult to integrate those different care services. So the government launched regional inclusive health support center that works for the integration, as well as consultation office for the integration, mainly run by Physicians Association. I'd like to focus on the regional health inclusive health support center. But before talking about the center, I would raise second challenges we face. That is, we need to reduce the number of beds. We need to reduce the number of beds. We knew that in 2015. So the first plan lasted 10 years. And here you see, we successfully reduced the number of beds. But if you look at the breakdown of these statistics, this part corresponds to the number of beds for acute care is decreasing. While on the contrary, this part corresponds to rehabilitation care or convalescent care is growing because there is growing demand for rehabilitation. So at 2025, we have acute care bed here and convalescent care rehabilitation bed here, but actual demand is shown here. We have smaller demand for acute care bed. On the contrary, we have more demand for convalescent care and rehabilitation care. We need to adjust to the demand, to the level of the demand in coming next decade. So the plan 2, the second term of the plan begins this year. So coming back to the Regional Inclusive Health Support Center, it provides opportunity to join for stakeholders to join in the same meetings, and it also provides many services like consultation, human rights protection for the elderly people, and frail prevention support initiative, etc., etc. And we have 5,400 regional inclusive health support center across my country. Each organization is very small. However, they are working for the integration and the seamless care. And this is also a very detailed slide. This slide explains how the nursing care insurance budget is spent. Obviously it's spent on nursing care benefit and preventive care benefit. But it is also spent on associated activities such as running regional inclusive health support center, etc., etc. Yes, the next slide says the same. The nursing care insurance budget is spent on the center. It also spent on the initiatives, community or regional initiatives to achieve coordination of home medical care and home nursing care. So this budget is also spent on the integration of care. And I talked about one of the budget, nursing care insurance budget for integration. We have another budget at prefecture level. We have 49 prefectures, including Tokyo. And so the initiatives funded by the prefectural fund need to cover all the prefectures. But we have the prefectural fund called the Regional Medical and Nursing Care Integration Fund at every prefectures. And if you apply your plan for integration or seamless care, your plan will be quickly approved by the fund, and you will quickly get the money. If the central government approves, it takes very, very long. So this fund works very, very quickly. Okay, another thing is that I said in 2024, medical care fee and the nursing care fee are revised concurrently. So at the very good opportunity, the Japanese government included new items that promote integration from seamless care. So there are many items. So in other words, if you try to integrate care at regional or community level, you will get more money. The financial incentives that is happening. I will show just one example. Here you see nursing care facility, home, and medical institution. Let's say that the patient is going to discharge from nursing care facility to return home. But at home, the patient continue to receive medical care from medical institutions. They need to collaborate. They need to collaborate for integrated and seamless care. And if care manager mediates those professionals between long-term care facility and hospitals to produce care plan for the elderly people, for the patient, the care money will get more money. So care money is now very actively working for the integration, being incentivized by long-term care insurance fund. I'd like to touch on briefly on voluntary initiatives, which includes Family Caregivers Support Program. The nursing care insurance fund is spent on families' support because families are taking care of their family members with frailty. So they work very hard. So they might be worn out. They might be stretched too much. So these initiatives host nursing care class to improve skills and knowledge for nursing care. It also provide money for initiatives to monitor and safeguard senile dementia patient, because we need a lot of resources for senile dementia patient. And another initiative is to invite family caregivers who might be worn out, who might be tired from nursing care. And then we chat to each other, we provide opportunity to build a network, and then we try to reduce the psychological and the physical burden of caregivers. So the nursing care insurance scheme is spent on these activities as well. Here you see the nursing care class, and then next slide describes the family meeting, family network, and we invite family people to reduce the burden. And we occasionally invite mild senile dementia patient to educate family members, because mild senile dementia people knows how they want to be cared by family members. So they are teachers. So we have initiatives like that as well. So I have talked about quality in long-term care, nursing care, social care so far. I'd like to focus on safety issue in long-term care in aging society. In early years after inception of nursing care insurance, there was no standard on safety in nursing care facility or nursing care settings. But in mid-2000, physical restraint and abuse of elderly were increasingly highlighted in our society. And then around 2010, reporting system was introduced to nursing care facilities. And nursing care industries learned a lot from medical care, acute care industry, like my hospitals. And they introduced analytical method, like root cause analysis, to their industries. And then after that, mid-2010 and early 2020s, Ministry of Health published a guideline on incident prevention at nursing care facility, highlighting standard prevention measures for patient fall, people's fall, and medication error. And number 3, food aspiration, and bathing accident. So this is really helpful to standardize the procedure or protocol to prevent those tragic events at nursing care facilities. And the government launched the subsidy, the fund for nursing care facilities when they purchase nursing care robot and the monitoring sensor. So the latest topic is that the guideline was revised by Ministry of Health again, and the government launched legislation on senile dementia issues, and it's incorporated in the guideline. This is the latest issue. This newspaper article highlights that many municipality governments collect incident data from nursing care facilities. However, only half of municipalities analyzes. This is a problem. This is a message from this newspaper article. So the government launched a big database to collect and to look at the individual incident case this year. And the government plans to analyze those data at prefectural level and the national level. So the government Ministry of Health once came to me, JQ, and then we have been still negotiating with this national level analysis of nursing care data, because the budget is not much. So we need to be very much careful. But this initiative is, I believe, very important. Okay, here you see the reporting and learning system, outline of reporting and learning system. And as I said, we publish a monthly report. So if you look at one of the monthly reports, it highlights the omission of prescription at patient discharge. You know, the patient receives the medication, but one medication is missing on prescription, or two medications are missing on prescription. It happens in hospital, of course, but you can say that this incident continues at home or long-term care facilities. So my message with this slide is that this type of incident happens or identified in many different care settings. So we need to learn each other in integrated care service delivery system. So, and probably this learning is boosted by digitalization or this digital technology that Japanese government is now promoting. The government is now trying to integrate all different health data related to our individual health into one big data. So we have smartphone, of course, and there is a platform called My Number Portal site. But My Number Portal site is Bukai. So we call it Minor Portal. And if we access Minor Portal, we know our healthcare data. This will be achieved in a couple of years. And we get 4 vital pieces of data from Minor Portal, such as referral receipt with discharge summary issued when discharged from a hospital, and the data of health screening, and the 6 clinical data of me, for instance, diagnosis, contagious blood microorganisms like hepatitis B or hepatitis C or HIV, and allergy to drug, allergy to other chemicals, laboratory data, recent laboratory data, and the prescription, and a summary of clinical history. So when a patient are transferred to our ER, emergency room ward, in Kyushu University Medical Center, and he or she had no history to visit my hospital, our physician in ER department visits this site, and then they get data, past data or previous data, and they start treating those patients. And the electronic prescription system is one of the key systems for safer medication therapy. Okay. And the people say that if the prescription is issued electronically, the system quickly found redundancy or omission or duplication or contraindication. So that leads to safer medication therapy. So my message is that reporting and learning system with the scope of all different kinds of healthcare settings works very effectively for integrated care boosted by digitalization. So this is the picture we are going to achieve in coming years. So last but not least, I still have 10 minutes. So I'd like to talk briefly about end-of-life care, the latest status of end-of-life care in my country. I said we see growing number of elderly people, particularly the age of 85 and older. The hospital do not have enough number of beds to accept all of the elderly people, and many elderly people dies one after another every year. So the number of people's death is rapidly increasing in my country. And what is important is that significant number of elderly people do not want to die at hospitals, they want to die at home. So the home care is quite important in coming decades. So the government defines 4 roles for home care. Number 1, discharge, consultation, and assistance. Number 2, daily care, of course. Number 3, end-of-life care, and number 4, acute care. And at home, a physician need to provide end-of-life care, not only at home, but also in hospital as well. So I'd like to talk about how we cope with end-of-life care, particularly discontinuation of life-supporting treatment, like mechanical ventilation or very critical medication for patients. And we went through 3 tragic cases in which physicians were found guilty of murder due to the discontinuation of those treatment in my country. For instance, the first case is that a physician injected high dose of potassium chloride and the patient died. Patient was suffering from severe illness, and so the physician decided to inject KCl. And the court ruled that the physician was found guilty of murder and suspended for 2 years. 2 years imprisonment, suspended for 2 years. And in the second case, a physician removed the tracheal tube in response to passionate demand from patient family members. But in this case, the physician was found guilty of murder. But in the Imizu Municipal Hospital case that happened in 2005, the judgment was different. What physician did is the discontinuation of mechanical ventilation. And the Ministry of Health and the police department scrutinized the case, and the physician was not indicted, and he was not found guilty. So the notion or the thought about terminal care has changed in my country. But still, we clinicians are really sensitive to withdrawing ventilators, discontinuing vasopressors, terminal sedation, and other end-of-life interventions. So we introduced the new words, death with dignity instead of end-of-life care, or assisted dying, etc., etc. So death with dignity refers to allowing a patient who is terminally ill and has no realistic prospect of recovery to forego or discontinue life-prolonging treatment based on the patient's wishes, so that patient dies naturally from underlying illness. Key features is that physician is not actively involved in death. It's a natural death. Death occurs through the natural progression of the diseases, and the patient wishes and autonomy are respected. So the government, the Ministry of Health, published the guidelines a couple of years ago, highlighting advanced care planning, which is the topic this morning, and confirmation of patient wishes, multidisciplinary discussion, family involvement, careful documentation, and institutional consensus. With those requirements, physicians will be no longer found guilty of murder in my country. Okay. Here you see the manga that describes the advanced care planning produced by the Ministry of Health. As you see, we love manga very much. Okay, this is the 5 takeaways. In the interest of time, I'm going to omit this slide, but I talked about the long-term care facility and quality and safety in AIDS society in my talk on these occasions. Well, this is a plaque that I was kindly donated by Professor Tsai last year in Sao Paulo on occasion of Taiwan Night. I am looking forward to the next plaque in Taiwan Night coming September. So thank you very much. Thank you all. Thank you.
Thank you very much for Professor Yoshida's excellent talk. Now the topic open for discussion. Any question from the floor? Okay. Professor, anyone? Professor Yoshida, I have 2 questions.
Yes, thank you.
The first question, you talk about the integration of medical care, nursing care, and the social welfare. But in the medical care and the nursing care, all we need is nurse.
Yes.
So how to estimate every year the education system, how many nursing school students you will have or plan, then you have enough human resource from the medical school to do your medical care and nursing home care. It's my first question. And the second question, you talk about AI integration with the nursing care, and you also enhance the digitalization in the medical care and nursing care. In Japan, how to integrate? Do you any plan to encourage the university or hospital develop new system or innovation to cooperation with the company or with the government to promote innovation?
Okay, thank you very much. And in relation to the first questions, at present in my country, the nursing care education programs are mainly focusing on acute care nursing and a little bit chronic care nursing. So after graduation, nurses, if they want to go to long-term care facilities, they join education course provided by regional professional bodies, and or they study on their own, and they pass the national certification system. But as you see, we see the growing demand for nursing care. So probably the subject or knowledge will be of nursing care will be greatly incorporated in the education program, which is issued by Ministry of Education in my country. But at present, it's not sufficient. So number 2, we are facing severe shortage of care staff at long-term care facilities. It's very hard, and many nurses, many care workers quit their job from nursing care facilities. So one of the national strategy to address the shortage is introducing a robot with AI. So the Ministry of Trade, Commerce and Industry and the Ministry of Health and the other related ministry jointly launched a subsidy, the government budget, for companies to develop robot for nursing care and watching the toilet, helping toileting action, or the watching the patient with a senile dementia, etc., etc. This is the highly prioritized area in our healthcare industry, which is heavily subsidized by the government. So I think I think we hope the innovative technology, innovative robot will be developed by those budgets in the near future. That's the future of my country. Yeah, thank you very much.
Thank you.
Oh, great. Thank you very much.
Do you have any other question? No? Oh, please.
Thank you. Thank you.
Professor Chen.
Thank you, Professor. Outstanding presentation. I have one question. Japan rely on practice-based legitimacy approach for end-of-life care, focus on advanced care planning and multidisciplinary dialogue and family discuss. However, Taiwan enacted the Patient Right to Autonomy Act. Clinicians still encounter legal anxiety when withdraw life support. How can we refine the clinical HCP decision-making process to provide better legal reassurance for care team? Yeah, okay. Thank you.
Yeah, thank you very much. I think that we share the same issues that we face. We share the same issue that we face. And this year, in June, I was invited by European conference, joined by European government officials, to talk about assisted dying or death with dignity. And I described our approach. But in European countries, some countries successfully launched legislation on assisted dying, in which a physician asks a patient about their preferences, and if they prefer overdose injection, physician prescribes overdose KCL or medication. And then physician doesn't do anything more, but patient inject the overdose medication to themselves, and they die. This is the institutionalized in their legislation. However, in Asian culture, for instance, in my country, let's say I am a patient. I don't want to die in my mind, but I am a heavy burden of family members. So officially, yes, I'm okay, I will die, so please give me overdose medication. But in my mind, I don't want to die. So we always pay attention to family members to see if I am a heavy burden on those associates or family members. So it's quite difficult to launch that kind of legislation seen in European countries. So we introduced advanced care planning, but now we are at the early stage of promoting ACP, but it's spreading. The idea of new generation is changing. And if we go to bookstore, there are increasing number of books that they want to decide on their own that the last moment of our lives. So I think the notion is changing, and the government is promoting, and frontline of healthcare workers are responding. So we worked synergistically to spread the idea and implement the practice of ACP across my country. So I believe that you will see a new generation in Taiwan as well quickly to accept ACP in the near future. So yeah, and we work together. We share our experience very frequently. Yes, that's very inspiring. Thank you very much.
Thank you.
Thank you.
1 minute. Okay, I have a last question. Professor, you know that Japan and Taiwan always the aging society, aging country. Yeah. Our GPT is similar, but our lifespan, Japan is 84 to 85. Taiwan is 80 to 81, almost 81. The gap is 4 years. 4 years is a small number, but the means is totally different. Do you have any suggestion to our government in the medical service from acute to chronic disease care, especially nursing care or home care, how to promote, how to fill up the 4-year gap Taiwan to Japan.
4 years. I think Taiwan is one of the leading countries who will successfully achieve the longevity, excellent longevity. So I believe that Taiwan will surpass the longevity of Japan in the near future. But the Japanese government is now spending a lot of money for care. So, but now the Japanese government is considering to spend money for prevention and the health literacy among nations. Maybe the prevention or the activity related to prevention is the focus that we need to deal with in the coming years. Yeah.
Okay, thank you so much.
Thank you.
Because time's up. Thank
Okay.
you so much
Thank
for
you very
your
much.
excellent talk. Thank you.
Yeah, 非常感谢，谢谢，谢谢，非常感谢。
Next, I would like to invite Professor Tsai to present the Certificate of Appreciation to Professor Ushiro. Professor Tsai and Professor Ushiro, please move to the front of the stage. Please face the camera and smile. Thank you, Professor Tsai and Professor Ushiro. Please return to your seat. Next, may we invite our moderator, Professor Zhang Shangchun, Chairman of the Joint Commission of Taiwan, to introduce our second speaker. Welcome.
Okay, it's my great pleasure and honor to introduce the second speaker of this afternoon section. And the next speech will be presented by Professor Fang Zhenzong. Professor Fang currently is the CEO of Joint Commission of Taiwan, 医策会. And he is an expert in the emergency medicine, and he served in National Taiwan University Department of Emergency Medicine for a very long time, since 1994. And he has been the Vice Director of the Department of Emergency Medicine from 2007 to 2013. And then he became the department chair director from 2013 to 2019. And he has ever been to be the president of the Taiwan Society of Emergency Medicine. And since 2 years ago, 2024, he was invited to take the position of CEO of Joint Commission of Taiwan. Today he will share with us promoting holistic and sustainable healthcare in Taiwan, and especially from the point of view of the Joint Commission of Taiwan. Please join me to welcome Professor Fang.
Thank you for Chairman Zhang's introductions. This topic of the conference is about the holistic healthcare. We know that the holistic healthcare is more focused on the whole body of the patients and not only directly go to the patient's disease. And we also know that the holistic healthcare is promoting for the patient self-care and self-management. So I think WHO also called this is the people-centered and the integrated care. So this topic of this conference is more focused on the whole system of the healthcare system, be focused on the people. Yes. So at our position at the Joint Commission of Taiwan, we promoting the healthcare quality for the whole Taiwan healthcare system. So at JCT, established in 1999, and until today is about 26 years. We were also promoting the holistic and people-centered care by several ways. The first is we want to do the patient-centered care. Is our past president, Professor Paul Xie, is our teacher. When he was the past president of the JCT, he wants us to do the disease-specific care certification. This kind of certification want to be patient-centered and more focused on the care team to promote a common goal and collaboration to help the patient to get a better health care. So in 2009, the first launched the disease-specific care in the Kasei General Hospital. I think the next speaker, our Professor Wang, is over here. He's young, look young, yeah. And at that time, that's the CEO of the Dr. Zhang, Dr. Ong, and our colleagues at that time. The first holistic care is caused us to paradigm shift from the patient, from the disease center to the patient center. So the clinical focus on the disease-specific care is to form a team, to make a care, and to promote better outcome, and for the better features of the promotion, the improvement of the cares. So the disease-specific care certification focus on the patient journey. So we want to know the patient journey. For instance, we use the care of the renal disease, for example. For we have the design, the implementation, we will focus on the core competence of standard of the renal cares, and the scope of the service of care model, the team communication, patient safety issues, and the data retention collections, and the shared decision-making with patient education. All these standards were into our disease-specific care certification standards. And also, the disease-based care investigate the specific equipment, environment, and the risk management of this kind of disease. So the whole program will have a quality management team, have a quality improvement actions, and the whole integration and the whole strategy management are included in our disease-specific care frameworks. So the JCT from 2009 to now, there is 19 disease-specific program now. The newest in these 2 years, we have the lung cancer, colorectal cancer, respiratory disease, stress syndrome of newborn, and we changed the renal disease into 2 disease-specific. It's focused on chronic disease and acute kidney injuries. So now it's all 19 certificate programs, all including in this kind of frameworks. So our country have more than hundreds hospital participants, different certificate programs. Now at the active certification in each DSC certification is about 15 to 20 more certification hospitals. All these hospitals are providing a better quality care of the disease. So we have two examples. One is the nephrology from NTUH, Taida University. They have joined the kidney-specific disease-specific care certification. They get a better outcome for the hemodialysis and the peritoneal dialysis patients. Another example from the southern Taiwan, the Chengda University Hospital. They have the disease-specific certification on the myocardial infarction in Taiwan. They show the improvement in the assessment, treatment, health education, and the prognosis. They have the improvement before and after they receive the disease-specific care certification. So JCT will promote the disease-specific care to the public. We know that public is the patient, is the people. They should know about the disease-specific care. They should have the chance to choose the better clinical performance institution to take care of their disease. So in JCT website, we have the area for the general publication to show disease-specific care, the healthcare promoting website. One of the disease-specific care during the website is the disease-specific care DSC area. So if you go to the disease-specific care website, we can show our DSC categories over there. And if you choose one of the category, like for example, this is the asthma, and they will show which region of your patients. If you in the Taipei city, you can show how many hospitals was certificate by JCT for the asthma care. And in the near future, we will show our key indicators at this disease-specific care. So every kind of disease-specific care, they have their outcome indicators. So we can show you the outcome in the integrated, all the data of this hospital can accept our certification. We can show you the data in the website. This data will be a good example of Taiwan national quality of the healthcare examples. So another is we know nowadays we want to have a sustainable healthcare. If we think sustainable healthcare is reduce the carbon emission, it's only one of the sustainable healthcare. The sustainable healthcare, the key component is how to reduce the disease burden. That's the key important. That's very important. If the people our population is healthy, they do not need to have the healthcare, so they do not use the healthcare to generate carbon dioxide. That's the most important. So like Dr. Yoshino previous talk, the prevention is the most important, the prevention. The patient self-care will reduce the disease complications, reduce the disease need to have to be taken care. Will also reduce the carbon dioxide emission. So we can see the sustainable healthcare is the holistic healthcare. It's the same. So if we have a good holistic healthcare, we also have a sustainable healthcare. So how is JCT will promote the sustainable healthcare? By hospital accreditation? Not good, not good. So we do not want to do something all by the hospital accreditation. So at our President Zhang's suggestion, the JCT launched a net zero healthcare category in the National Healthcare Quality Award. We have a National Healthcare Quality Award for many years, you know that. So many years, each year, many hospitals participate this kind of campaign for the want to get in the award. So in next year, we get a first new category of the net zero healthcare category. The key focus is due to, we know that in 2050, the whole world want to have the net zero emission goal. Our government also commit to achieve the net zero greenhouse gas emission by 2050. So our healthcare providers also need to have this kind of reduction of the carbon dioxide emission, the goal. We also have to do that. So in JCT, the NHQA, National Healthcare Quality Award, established in 2000, till now is more than 20 years. In 2023, we think the ESG is very important. So we began to have the ESG Special Award since 2023. Now, in 2025, first we get the category of the Net Zero Healthcare Award. So the Net Zero Healthcare subcategory have the 3 subcategories. So Net Zero want to have the solutions of the Net Zero. So that's called a specific thematic area, like the low carbon mailbox, green procurement, and so on. That's called the solution. Another is the service subcategory. A specific service process or disease care pathway can have a better low carbon emission pathway. Maybe we have a hemodialysis process. We have a lot of waste during the hemodialysis. So how do we reduce the waste, or how to reuse this waste to get a low carbon emission process? The third is the whole institution, the category. So if the whole institution is focused on the many services and many solutions, they can choose the institution Net Zero Healthcare subcategory. Our award judgment will have the 6 core principles of evaluations. One is the organizational impact. Another is executional method and design features, and the data analysis performance evaluations. And we shall see the strategy management, information disclosure, and scalability. So the judge will go each hospital, each institute, join this award campaign to see which all of these 6 principles. So I will show you the inaugural participant overview next year. The first time we get this Net Zero category, we do not anticipate so many participants. But to our surprise, there are 30 institutions to submit their the program. And there are 11 medical centers and 8 non-medical centers. Mostly are focused on the solution. That's called one thing, one topic. There are several, they are used 3 service category, and 8, they have the institutional categories. The solution topics, most of the solution is focused on the waste and energy saving, waste reduction, or reuse the waste. And some we use the green procurement and others, digitizing measures to reduce the paper use. So overall, the topic is focused on the equipment optimization, digitalization, waste reduction, and the resource management. With strong feasibility ability to quick demonstration of carbon reduction result. And the service participant are only 3 teams, so we think it's quite difficult to get our hospital to do fulfill the criteria to do a very good net zero process to show the improvement of the carbon dioxide emission outcomes. Some healthcare institutions have begun to promote actions from governance and the strategy level, so they joined the institution net zero campaigns. So this first year's results of our net zero healthcare category reflects the involvement of the healthcare quality by emphasizing both patient health and environmental sustainability, while encouraging the healthcare system to become a key driver of national net zero transition in the sustainable futures. However, the National Health Council Award promote this net zero campaign is an exchange platform for us to learning from each other to promote that kind of strategies to become more and more art institutions can use this kind of methods. So that's my topics ending with, because we have a patient-centered care and net zero healthcare quality. This kind of specific disease certification is not like a net zero emission. It's quite different, but you can see there are some relative. If we have a holistic and integrated care, we'll also get a process change, and you will also get the carbon dioxide emission reductions. And the sustainable healthcare is provided by prevention and disease reductions. Thank you for your attention.
Thank you, Dr. Fang, for very clear introduce about how Joint Commission of Taiwan to promote the holistic and sustainable healthcare. Now we still have several minutes, so the speech is open for question and comments. Is there any question or comment from the floor? No. It seems very clear. Okay, anyway, Joint Commission of Taiwan has been established for 27 years, and is the most important organization to promote the patient safety and healthcare in Taiwan healthcare system. And this is only very small part of the job Joint Commission of Taiwan has done. And actually, we still have many plans or many activities to promote our healthcare qualities in Taiwan. If no any comment or question, I think maybe we can close this talks earlier. Thank you, Dr.
Thank you,
Fang.
thank you.
Next, we would like to invite Professor Zhang to bestow a certificate of appreciation to Professor Fang. Professor Zhang and Professor Fang, please move to the front of the stage. Please face the camera and smile. Thank you, Professor Zhang and Professor Fang, and please return to your seat. This concludes this first part of the session. The next session will begin at 3:20. Please return to your seats before the session resumes. A bell will ring 5 minutes beforehand. We now invite you to take a short break. Refreshments are available outside the conference hall. Thank you. 现在进入休息时间，下一场预计于3点20分开始，敬请各位长官及贵宾3点15分前返回会场。会场外备有茶点，敬请享用，谢谢。
for the Professor Chen's introduction.
Ladies and gentlemen, the second session will start shortly. Please take your seats and ensure that your mobile phones are turned off or set to silent mode. Thank you. Ladies and gentlemen, welcome back to the International Symposium on Holistic Care and Healthcare Quality 2026. It is my great honor to invite our moderator, Professor Cai Yiting, Superintendent of Tri-Service General Hospital, to the stage. Please welcome Professor Cai.
Good afternoon and welcome to the afternoon session. So this session, that's my great honor to introduce the first speaker, Dr. Wang Bachun. He is very famous in our health. Okay. So he is so far he is the vice president of Casey General Hospital, and also is the attending physician about the ENT. So today he will give us a talk about the current state and the change of the quality management. I think everyone should be very familiar about this topic. Professor Wang share with us. So let's welcome Professor Wang.
Oh, thank you for the moderator and Professor Cai, two Professor Cais. Now today is my good friend, Professor Xin is here. So otherwise I will speak in Chinese. It's better to understand. But I have to speak in English. Okay. So today my topic is healthcare quality, present and challenge. So I will share with you some thoughts in my mind. So what's happening now and what's my thoughts? Okay. So Taiwan has boost for our so-called healthcare quality. 我有时候用中文解释一下，就台湾都自己觉得自己医疗品质非常好。Taiwan always think we are very good in health quality, but actually, we are talking about the clinical quality, okay? The technique and the skill of the physician is not a comprehensive medical quality we talk about in the quality industry. Why? Because the healthcare industry is very diversified. Traditionally, all the focus is on the acute care. The big hospital, the smaller hospital, the small hospital, the hospital accreditation, push us to go further, better and better. But what we don't know is that we have the health management, 健康检查, physical examination. We have the preventive medicine. 现在外面在做那些抗老化一大堆，and also the aesthetic medicine， 整形自费美容诊所，蓬勃的发展，also 这个长照机构 long-term care。那么这些部分 完全没有 cover 到，所以我们的 healthcare improvement we only focus on the acute care. I can tell you, because other parts are all in the infancy. The no healthcare improvement, I can tell you. So the fragmentation is a threat to quality and safety because the acute care, the primary care, the long-term care facility all have very different perspective about quality. So if we don't forget, not long ago, something happened in the plastic surgery clinic. So the government say, oh, we want to do the accreditation. So of course, all the clinics, they oppose that. 他们都一定是反对嘛。So they say, oh, we want certification. 他们要认证，不要评鉴。So this is very wrong because 我们这个医疗the quality has a 3 level. The first level is so-called the standards of establishment. 就是设置标准，所以 that's 60%， that's 就是及格，60%， 60 points 及格 pass. You pass the approval rate, and from 60 to 90 is the range of acceptable of quality. 就是一个可以接受的范围，就是评鉴它是60分到90分。那么 if your quality is better than 90 points, you exceed 90%, so you are qualified to receive the award, to receive the specific certification. So they are totally wrong. They are not even meet the standard. How can they pass through the accreditation? So says that we want the certification. They just don't want accreditation. Okay, so that's a very, very fragmentation industry in Taiwan. I can tell you, because the hospital, acute hospital, only account for 40% of the healthcare capacity, and our long-term care part is increasing in a very fast pace. And the other issue is that the equity issue. So for many years, Taiwan also boosts the national health insurance. That helped us to eliminate the equity issue. So we think we are equal. We are equal to people because everybody can access to the national health insurance. But actually it is not. Because the geography, we still have some very small islets outside Taiwan. We have a finance problem because the rich hospital and the poor hospital, they have very huge financial gap, and also the digital gap, because in the acute hospital, in the big medical center, we devote much resources to improve our health information system. But in the primary care, in the long-term care, it's a very, very primitive. And also the minority people and the very remote people. So accessibility, we have accessibility problem, but it's not only the geography problem, like in other countries. We have a national health insurance, but some places have the insurance, but they have the insurance coverage, but they don't have very good health care. So that's a very different type of the equity issue. It is the chaos of aesthetic medicine. So I like to ask, how many more patients will need to die before the public wake up to do something? Okay, so every day we will see something happen in the aesthetic medicine. But the government has very little they can do to regulate this clinic. In the past 6 to 7 years, all of my students in the otolaryngology training program, when they graduate, they devote themselves to plastic surgery. Even during the 5 years resident training, we didn't train them to do many aesthetic procedures, But when they graduate, they can do a lot of aesthetic procedure to their patients. So there's a mismatch of the education. So to my age, I kind of lost my passion in education, because when I teach them, I'm afraid that my student laugh at me in my back. So why'd you teach me this? I don't do the surgery when I graduate. And our manpower in our society is all centralized, because our Ministry of Education and the Ministry of Welfare and Healthcare, they control all the supply of the healthcare professional. But right now, the young people, they vote using their feet. So they don't do what they were educated to do. So that's a big problem. So it's not only people don't want to stay in their job post, because that's an education mismatch. So we spend, every year, we spend so much time, we spend so much energy, resources to teach our residents, but to the end, they don't do ENT. Okay? So, here, the dermatology, the ENT, the rehabilitation, ophthalmology, the small specialty, our RRC resident position are very, very competitive. So year after years, they raise up the standard again and again and again. So made all the faculty live in a very difficult life, Even you are getting very old, you still have to work with the paper, with the resident, But what is this for? Because you improve all your education quality. But when they graduate, they don't do this, They laugh at you in the back, Why do you teach me to do this surgery? I don't do this, when I graduate. Okay? So that's a very, very big problem. I think all the faculty here need to think about. And the market itself is profit-oriented. So it kind of distorts our ethic and even the safety. Years ago, when I served as a CEO in the Joint Commission of Taiwan, I went out to the disease-specific certification tour to some clinic, You see many, many very strange things. Very, very strange. You cannot imagine, okay? The machine they use, is even worse than the machine you use for your animal study in medical school. And they do a very, very, all kinds of very strange things, all for money. And although some self-pay clinic, they are practiced under the great area, because all the generation medicine, the genetic medicine, and the exosome, all these, are not legalized. Even in big medical center, we are very, very conservative, because all the effects are not very certain, But in this clinic, they have done this, very popularly. And the government doesn't know. So it's innovation or something quicker. Is a great area. And there is no SOP and no law to regulate to all these procedures in the self-pay clinic. And although the population transformation brings up the huge healthcare burden, in previous talk by Professor Shin, we are like 15 to 20 years behind Japan. So we should learn more from Japan, So the path they walk, is the path we will go, or right now in the past. So that's a huge healthcare silver tsunami. Our super aging society and the multiple comorbidity bring the huge burden to the healthcare. So our acute care and the long-term care capacity is already overloaded at the breaking point. So just think the budget of the long-term care budget， 在我们小英总统是30亿的新台币，那现在在赖总统已经超过了1000亿的新台币，1000亿的新台币。It's about how much in Japan yen? Anyway, it's 差不多超过30倍以上的啦。那这个很大，但是问题是 we are not ready for this. And as I mentioned, the quality and the safety of the long-term care facility, they are still at infancy. And although you can read from the newspaper that people are against the accreditation, against all the quality improvement, 因为这个 long-term care is not so profitable as we thought, so they kind of try to reduce all the manpower. They try to reduce all the investment, and the nurses tend to be very senior because they retire from the acute hospital. So if you want them to do more, they don't want. They want to retire there. They don't want to do more. Yeah. So there's ever increasing demand for the healthcare, and it's very weak standards for care, and very weak accreditation power. And the other things I like to argue, why quality prodigy fall from cloud? Okay, so I learned this story from Professor Shin. I asked him, what happened to Tokyo University Hospital in 2022? Because last year, so very, very big things happened. Because the big hospital leader in Taiwan, they argue to the present line. They want to say, oh, that too many paperwork, there's too much burden of the accreditation, of the hospital accreditation. So they want to lengthen the accreditation cycle from 4 years to 6 years now. Okay, so at that time, the ministry emergently asked us to do the survey. So we survey the accreditation cycle from all advanced countries. Most of the country have the accreditation cycle from 3 to 4 years. Very, very rare. Japan, 5 years. 5 years. Spain, 5 years. Very, very rare. Nobody do the accreditation cycle 6 years. Nobody does this. Why? Why Taiwan is better? Why Taiwan is better? So we look into the story of Tokyo University. You see, in 2022, Tokyo University Hospital failed in 4 accreditation items. 他们要做那个追踪访查，4条没有通过，应该委员也不敢随便当他们啦，Surveyor will not easily flunk Tokyo University, right? Unless they have a very strong evidence say you didn't do this right, okay? The safety system not good. They didn't do the incident report very seriously. The process management has some problem, and their medical records need integration. This is a comment. This is a comment from Surveyor. This is a comment from Surveyor from JQ, Japanese Quality Accreditation Council. Shin is the board director. And the Tokyo University Hospital, the president come up to apology to the society because they are national hospital. They apology and they improve immediately. They receive the recertification next year, right? 他隔年马上就道歉，因为他没有过啊，4条没有过啊，这个都是必要项目啊，病人安全废掉，所以呢，我觉得，所以 I think the leader of Taiwan's medical center, you better not say so. There are a lot of paperwork of the accreditation. That's your leadership problem. So you should tell the society that my quality is equal, is the best, 365 days a year, same. I follow the standard procedure to take care of my patients. You don't say that you are doing the paperwork before the accreditation. That's a shame. 我真的私下跟某国立医学中心的院长，我有跟他讲，这千万不要在社会大众面前讲这样子。The first thing is that, okay, and the second, right now the accreditation cycle becomes 6 years, okay? So you need to keep the tension. The leadership of the hospital need to keep the tension. 因为 6 years is really too long, really? Okay? Because nobody does that in the world except Taiwan. So 这是一个非常草率的决定，没有经过 policy 的 debate. 所以呢，在这个过程当中 you need to keep the tension of the hospital. Otherwise, you will lose a whole generation of the people who understand quality, understand safety. 好，就是说6年之后我们也都退休了，我也不在位置上面了。好像我这本身在做这个。So after 6 years, I retired. Nobody understand quality. Recently, I have some feeling because I attend some committee in Joint Commission Taiwan. So I found they recruit some new members to the committee. What they are talking, this sounds very familiar. Déjà vu. Okay, something we talked 20 years ago. That means we are coming back. We are still there. We are coming back to where we started 20 years ago. That's very, very dangerous. So here, quality improvement is a continuous work. So from this graph, this is a very classic graph from AT&T, because the quality is like a football. You either going continuously improvement, but you need some audit to stop from falling down. So this is very important. You need an external audit to keep the quality to improve continuously. 我们不要自己自毁长城，这是很重要的。Okay? Then, the workforce shortage, is a big crisis. How's that? Because if your team has replaced 30% of the nurses, basically your team, they're all new staff, 都是新人. So they are not familiar with the SOP in your team, in your unit, and the culture of the patient safety is interrupted. 所以这个是一个 big threat. And although there are many papers saying the ratio, the nurse bed ratio, is related to the mortality of the patient, but the problem is that the hospital don't want to pay more to hire a nurse. Is that there is no nurse in the market for you to hire, and not only the nurse, the pharmacists. So all the pharmacists are hired by the chain drugstore. They now becomes a salesman. They are not the pharmacists anymore. 他们现在变成那个连锁药妆店的推销员，他们不再是药师了。那么 so there are no pharmacists in the market, but the pharmacists and the nurse association, they still push away a lot of advocacy. 要人家布病比要怎样怎样啊，这就请不到人了啊，你还这是 is to me I think it's suicidal. Suicidal. So nobody in the market, nobody in the job market. It's not that the hospital don't want to pay more for these professionals. So at the top management, because the national health reimbursement always change, and it's very difficult for us to hire qualified people, even with higher pay. And in the middle is a big attrition, low efficiency, and the people fatigue, frustrated, and more people leave, So it becomes a vicious cycle. And in the bottom, you don't have enough people to accumulate the experience, and the quality and the safety culture are interrupted. So I think it's a very, very big problem. Okay, because I am on the quality director's post in my hospital for 20 years. So the education, we continue to do the education, but you have very frustrated, been very, very frustrated because you have to do all this training, do all this teaching, again and again and again. And all the incident report, the problem appear again and again. So that's the source of the of frustration. Cultural, safety cultural disruption. Okay, and the other things, we need to see something more positive. Okay, so last year when I went to attend the ISQA in Brazil, I see the booming of the AI. So in this past 1 year, you see the change of the world is very fast. So right now is 工业革命啊，就是那个 Industry Revolution 2.0. So when I come back, I talk to my colleagues. I say we need to introduce the AI into the quality management. So after that, we opened up the many new projects. Right now we are sailing into the deep water. Why? Because it's not so easy like what was published in the media. It's not that easy because AI is very, very powerful. But healthcare is a little different because healthcare, we need a very precise, we need to responsible. So how do you use the AI precisely, reliably, very safely in our daily healthcare work? That's the big problem. So that's what I say is we sail into the deep water because all these different projects, we met some obstacles. We need to overcome it, When we overcome it, we find a solution. So we will use the AI very safely. There is high expectation for the efficiency and workload reduction. But if you cannot fit the AI well into your workflow, you conversely will increase the workflow, not reduce the workflow. A recent paper published in JAMA, the Stanford team, they study the nurse summary by AI. So they say 20% of the output of the AI needs manpower correction. So 20% is big number. So you may spend even more money, more time, to correct all the output. Rather you can write by yourself. Okay, so it's a big AI, in big technology overhaul. So we need to reshape our clinical decision pathway. And the provider and patient interaction has been totally changed. So the hospital need to implement a new infrastructure, computation power and storage power. So we need a very good governance, and we need to face the new safety risk and the quality pitfall. So we need a high level of the AI governance and to focus on the privacy and ethics and to validate the model. Okay? So 我们要重新把这个纳入 we need to re-engineer our process. 好，这太多了 Twilight. So this part, Dr. Fang although mentions is how to improve the care. The new Twilight is to human-centered care. 就以人为中心的照顾，这 care cycle. So we need to re-engineer our incentive in the insurance payment, which is the pay for quality, to integrate the departments. And we need to focus on the patient-reported outcome, which is the experience of the patient when they receive our service. So this is a trend of the DSC mentioned by Professor Fang. 好， so in the future, I would suggest that we need to really face the problem of our accreditation to do the quality improvement work in our daily work, not just before the accreditation, to incentive the re-engineering. Okay, so we need to change our incentive from volume to value. Thank you.
Okay, I find Professor Fang can shift from the Mandarin and the English very smooth. So any question or from our floor? Please.
Thank you, Professor, for your excellent presentation. I have one question. As hospital accreditation shift to unannounced continuous indicator monitor and measure potence volume-based healthcare model pay for quality. So how can quality management assist clinical department in incorporation patient report outcome mature points to effectively transition our matrix from volume-driven to value-driven care. Thank you.
Okay, so previously, our healthcare in Taiwan, we focus on the efficacy, effect. So the patient, the mortality, the infection rate, such and such. So right now, patient experience is very important. So in the quality management work, we do the patient satisfaction survey and also the patient reported outcome. So recently, we received the newsletter survey. They ask how many procedures, how many care processes you evaluate the patient reported outcome. So I think this will become routine. So every department, every care process, you need to consider this. You need to ask your patients, what do you feel? What's the quality improvement after our service, after our treatment?
So, any question? Okay, so I think we should move to the next topic. So,
next, I would like to invite Professor Tsai to bestow a certificate of appreciation to Professor Wang. Please move to the front of the stage. Please face the camera and smile. Thank you, Professor Tsai and Professor Wang. Please return to your seat. Now, we would like to welcome our moderator, Professor Chen Dengwei, Deputy Director for Information of Tri-Service General Hospital, to introduce our last speaker.
Okay, good afternoon, distinguished guests, dear colleagues, and ladies and gentlemen. Welcome to today's last session. As healthcare evolves, transforming our clinical interactions through shared decision-making has become a critical driver of quality, medical quality. I think today I'm very pleased to introduce Dr. Hong Zhichong, Director of the Department of Dermatology. Dr. Hong and his team has successfully integrated SDM, shared decision-making, into his business, his busy outpatient clinic setting by developing specialized patient aid, I think it's PDA, for conditions ranging from psoriasis to and atopic dermatitis to aesthetic procedures. They helps patients weigh their options and align treatments with their values. Their effort has not only improved patient satisfaction and communication, but also earned national recognition as a healthcare quality benchmark for our hospital. In today's talk, Philippine the clinic building a national benchmark for healthcare quality through shared decision-making. Dr. Hong will share their experience in cross-team collaboration and workflow redesign. Please join me in welcome Dr. Hong Zhichong.
Thanks for the Professor Chen's introduction. And my topic is the Philippine Clinic. In the next 20 minutes, I want to share with you our 8-year shared decision-making experience and how we get the national award. And in 2023, our society have holding a meeting that I have a speech to share our shared decision-making experience. And previous chairman of the JCT, Professor Lin Qizhen, conclude what I did in the shared decision-making into 4 aims. The most important aim is to improve the patient care quality. And the second, I have been published 3 articles in different skin disease about the implementation of the shared decision-making. And the third, until now, our team have received 6 national awards. And besides, I have extended my shared decision-making experience into the medical education. One article has been published and another one is under review. In 2018, our team have built a patient decision aid for the atopic dermatitis and get a National Silver Award from the JST. In 2023, our team get the first symbol of nation quality through the implementation of the SDM. In the same year, our team have to improve the patient safety through the educational video, get a National Excellence Award. In the 2025, we get a second symbol of national quality through the shared decision-making in atopic dermatitis. And in 2026, we got 2 Excellence Awards about the shared decision-making from the JCT. So today, I want to share with you from the SDM to the National Award. But actually, this journey is not so smooth. Actually, we face the challenge and difficulties and frustration. And today, I want to share with you how we face the challenge and how we fix them. The first challenge, that's back to the 2018. These tools that we built with the graph to explain the pathogenesis of the atopic dermatitis with the guideline of the atopic dermatitis, we use the icon to explain 2 different kinds of treatment efficacy, including the phototherapy and the oral treatment, oral immunomodulators. We have the items to check the patient if they are ready or not to do the shared decision-making. The tool goes through the whole procedure, have the alpha test, the beta test, and the user test with modifications and use and launch. But however, the real-world clinical problem is that patients with atopic dermatitis only see the physician when the disease flares badly. Besides, their understanding of the treatment stops at the steroid. Nowadays, we have so many treatment options for the atopic dermatitis. We have the topical agent. We have steroid and non-steroid ointment. We have the phototherapy. Narrowband UVB can reduce skin inflammation, reduce pruritus. We have the oral treatment. We have the antibiotics. We have the steroid, but just short-term use. We have oral immunomodulators. We have the methotrexate, cyclosporin, azathioprine. But this kind of the treatment got to regular blood examination. We have the powerful biologics. We have the small molecule JAK inhibitors can relieve patients' pruritus within 1 week. However, there is a huge gap between what the patient knows and what modern treatment offers. We want to reduce this gap through the shared decision-making. Compared to our tool. Our tool compare about the phototherapy and the oral immunomodulators. But actually, in the real world, these 2 kinds of the treatment can be combined, can be combination. So in the real world, there are so many treatment combinations are possible. But our tool just focuses on the few specific scenarios. So the first challenge is that the existing patient decision aid doesn't fit the real-world clinical use. So let's talking about the second challenge. Before the second challenge, let's go through the 3 steps of the shared decision-making. The first step, our physicians got to explain the pros and cons of different treatment options. Second step, we got to give the time for the patient and their family to consider what they matters, maybe about the treatment efficacy, treatment safety, or the budget. And the third step, a physician got to discuss with the patient and their family to make a treatment plan. So the shared decision-making is it's most important to invite the patient and their family take part in the treatment decision. And the patients should understand what ongoing treatment is needed. The most important about the shared decision-making is increased patient engagement. Because patient engagement will affect the treatment compliance and the satisfaction. So in the first step, we want to reduce the gap. But this gap, not only limited to treatment, but also the disease. The universal guideline about the about the atopic dermatitis, the first line is not the drug. The first line is the physician got to tell the patients, you got to apply moisturizer diligently. However, if we just told the patient do it, no, we got to tell them why. So I'm using the damaged brick wall to compare to the atopic dermatitis skin. It's damaged. The damaged skin will contact with the allergen and the irritant and induce inflammation and pruritus. So we got to tell them you got to apply the moisturizer frequently to get your skin barrier function back, and you can reduce your skin inflammation and pruritus. In the first 2 years of my attending physician, I using the handwriting to communicate with my patients. However, my clinical sections is so busy. There are so many patients, so my handwriting is messy. So patient cannot read it. So what did I change? I using a PowerPoint. Nowadays, I using a PowerPoint to communicate and educate my patients. I using a PowerPoint to tell the patient why you got to treat the oral antibiotics continuously for the acne. Do not stop the drug by yourself because it will cause antibiotic resistance. About the onychomycosis, I didn't just give them the topical agent. I got to tell them, you got to trim your nails thinner, then apply the topical agent. Or the topical agent cannot absorb by the nail. The difference about the pruritus on the feet, there are two important differential diagnoses. One is pampholysis, another is the tinea pedis. They are totally different. The seborrheic dermatitis all over the world treatment is steroid. However, before the topical agent treated, you got to apply the facial lotion first, then apply the topical agent on the erythematous area. The foreign body on the feet, we got to differential diagnosis about the warts and cones. They are totally different. So what did I do in the atopic dermatitis? This is the paper patient decision aid. I changed it into the PowerPoint. Using the PowerPoint, I can use in the graph to explain to the patient and the family about the pathogenesis of the atopic dermatitis. I using a damaged brick wall to tell the patients you got to apply topical emollient frequently. I want to let them know they are not alone. In Taiwan, there are 2 million patients with atopic dermatitis. The disease is so complicated. There are so many cytokines and immune cells involved in the pathogenesis. So there are so many different treatment options for the patients. I'm using a graph to tell the patient we have a steroid, we have non-steroid topical agent. I'm using a graph to tell the patient what's the phototherapy. I'm using a graph to explain to the patients what's the biologics. However, even we change the patient decision aid tool from the paper to the PowerPoint, it still takes 10 minutes to explain to the patients. It's still time consuming. There are so many barriers for us, for the physician, to implementing shared decision making. The most important is time consuming. Another, maybe the physician is not familiar with the tool content. The tool content is not suitable, or the patient have low health awareness. No team support for us to perform the shared decision making. Patients have the barren willingness to take part in the shared decision making. Several barriers cause the shared decision making from the just do it to the just do it later, and later. So, in the real world clinical sessions, there are so many patients, maybe 60, 70 patients in each clinical sessions. But the shared decision making, it takes time and effort. It's too time consuming and hard for the physician to carry out shared decision making in the real world. So I changed the delivery way. Flipping classroom is the teaching method I taught the UGY, PGY at the hospital. There are 3 steps. Our teacher give the students educational video. They got to watch it at the rest time. And the second step is the in-class discussion. During the class, I can answer the students' question directly, and I can emphasize the importance. And the third step is post-class review. So what did I do for the shared decision-making? I changed the PowerPoint into the video and upload to the YouTube. And it can have the QR code, and patient can scan the QR code by their own mobile phone. So the three steps. The first step, the patient and their family will get the QR code and watch the video in the waiting area. When they are ready in the same stations, they will come back my clinic again. We can discuss with the patient and the family directly. I can answer the question directly, and that's made the treatment plan. Besides, it can be repeated reviewing. Because the shared decision-making is dynamic, the initial treatment plan doesn't achieve the treatment goal. We got to change our treatment plan. But when the patient forgot the treatment options, person comes, they can watch the video again. So in the real world, patient come to my clinic, I give the correct diagnosis, I will give the QR code. I have designed the pre and post knowledge test and the feedback questionnaires. I have the video QR code, and patient can get a QR code outside in the waiting area using their own mobile phone to go through the whole process. In the same session, they will come back again. I can discuss with the patient with the effective physician and the patient communication. So in the traditional 3 steps, it will cost at least 30 minutes. But after the free classroom, the first step and 2 steps can be completed during the in the waiting area. So the time can reduce to 10 minutes. 30 minutes to 10 minutes is from the impossible to the practical. So the second challenge is we got to rebuild a new patient decision aid, and I changed the delivery method into the free classroom. So the third challenge is the objective data collection and article publication. So during the 1 year and 6 months, there are 129 patients complete the video-assisted shared decision-making. And I have designed multiple choices questions for the patients to ensure medication safety. So after the reading papers, the score was 77. After watching the video, increased to 94. And subgroup analysis by the sex and age produced the same result. That's the score of the different age and different sex. But the most important is patient preference about the patient decision aid tool. The blue bar is the video, and orange bar is the paper, and gray bar is the same. There are 73 out of 129 patients chose the video is better. And subgroup analysis show the same result. Besides video certification is the paper. And quantitative feedback, patients show that the video explains things in great detail and easy to understand. That's the questionnaires Likert 5 scales about the shared decision-making certifications. The shared decision-makings can let the patient understand treatment options to give them a chance to raise their questions, promote the patient participate in the care process, and promote communication. Make the patient trust the team's management and lower their anxiety. This 6 questions just show one. Increase the patient engagement in the clinical process. So the positive effect, the video helped the medical shared decision-making become convenient and fast. It's standardized about the clinical explanation. It can repeat playback because patients have different health literacy. So that when the patient have low literacy, don't worry, it can stop, pause, or it can play back. It can change the speed of the video. Besides, it can lower the overall medical and time cost. However, negative effect, maybe the elder patients cannot familiar with the electronic device operate. But don't worry, our nurse, our resident, they are team members. They will help the elderly patient to operate their cell phone to scan the QR code. And our data have been published in the Dermatologica Sinica. And what do? We use in the video, we use in the Google phone, we use in the QR code in order to increase patients' knowledge and medication safety. It's to fulfill the holistic patient care. So the third challenge is run the shared decision making and collect the data and publish the articles. So from the SDM to the national award, we got to conquer these three challenges and to get this. So what's the purpose, what the clinical problem that we want to change after shared decision making? We want to let the patient know, work with your physicians to adjust the treatment plan. And nowadays, we didn't just have the steroid, we have more than that. We have topical, we have phototherapy, we have oral treatment, we have biologics. So the experience that have been shared in 2025 ISQA, and in this year, I will go to the ISQA again, and this time I have the chance to give the lightning talk presentation. And this is the photograph in 2025 ISQA. Okay, and I have been invited to our society, to the different department at our hospital. The most important, I have been invited to other hospitals, and I have published the papers in a journal. So in the real world, the Taiwan medical busy clinics, how can shared decision making actually be put into practice? We through the video and flipping classroom teaching mode, shared decision making is implemented in the clinical. So today my topic is flipping classroom. I share with you our shared decision making experience and how we get a national award. Thank you.
I think I've heard a very excellent speech. First of all, I think Dr. Hong has achieved almost mission impossible in the real world. So I still think that during the very busy clinical setting, how can you achieve that? But somehow he said his resident here, a very strong team to achieve this. Previously, I heard Dr. Wang's speech. I feel a little bit distressed. I think that maybe it is the wrong road to achieve excellence of our medical quality improvement. But somehow, I see light in you. Okay. Is there any question from the audience? Okay. If there is no any question, I'll ask a first question. I think in your presentation, I think you give the patient's family or the patient their medical, I think it's a video on medical condition and upload them into the YouTube. And why not just display the establish the QR code just outside the clinic, and they can scan them independently instead of you have to let them the pre-clinic consultation on the YouTube. How do you do is this? Is that right?
Yes. Thanks for the moderator's questions. These questions are very important because these questions have been proposed by the SNQ judges. Why I didn't put a QR code video, QR code outside the clinics? Because I'm afraid the patient scanned the wrong disease video. When the patient is psoriasis, but he scanned the atopic dermatitis. Now he come in my clinics, but we cannot discuss in the right way. So that's the reason I make the QR code. Our physician give the correct diagnosis and give the patient. That's the reason.
Okay. So I see in your paper you mentioned that you have 136 patients complete the SDM test in your clinic. And so it's almost 1 year and a half, 18 months. So the number is not that large. So do you think you need maybe environmental supplement, for example, the PDA or computers or something like that, or also the physician aid during your clinic?
Yes, thanks for your questions. Because I want the patient can use their mobile phone to scan the QR code. So if the patient's device cannot scan, we will provide them. But the most important shared decision making I perform only in the atopic dermatitis first time to our hospital. So there are 129 different patients. But actually, the numbers increased right now. The numbers that I analyzed is 6 months ago. So I think the numbers will increase right now. But I want to cooperate with the local clinic. We want to have the cooperation with them to eliminate the boundary. That's the first sections in these meetings. We want to eliminate the boundary to let the patients can get more efficient treatment from the clinics.
Thank you for your understanding and explanation. Yeah. So if there is no more question, we will close this section. Okay. Thank you.
Next, Professor Chen will present the Certificate of Appreciation to Professor Hong. Please face the camera and smile. Ladies and gentlemen, we will now begin the Outstanding Poster Award ceremony. First of all, we would like to thank all presenters for sharing their excellent research and valuable contributions. After careful review, the Outstanding Poster Award has been selected. Congratulations to all of the award recipients on your outstanding achievement. As I announce your name, please come forward to
Professor Tsai and Superintendent Tsai and our distinguished guest. I think today we have very fruitful conference, and we are talking about holistic care and how to improve our healthcare quality. I always remember that Professor Wang told us the healthcare quality is like a break of the medical care system. So if we have this kind of system, we can let our clinical patient care go very smoothly. And I think from today's conference, we will know that we should do the patient-centered thing, and we should have the comprehensive and the holistic care. That's also our mission, in the mission of our hospital. So to improve the well-being, I think I should end this section very quickly, and because now maybe we will go for dinner and go for any other things. And thank you very much for your participation. Thank you.
Thank you once again for your attention and participation. We look forward to seeing you at our future events. Please don't forget to take your belongings with you. Thank you and have a wonderful day. 感谢各位贵宾的参与。